అవునండి. A gentle request to all my dear students, please make sure that all your audio is in mute. As Albert Einstein once said, education is not learning of many facts, but the training of minds to think. This is what we Annoor Dental College and Hospital believes in. Good morning, one and all, and welcome to Exam Tips 2021, a state level review program for third year undergraduate students focusing on oral pathology and microbiology, launched by Annoor Dental College and Hospital, Muvatupuzha. Myself, Dr. Sinju Paul, Assistant Professor, Department of Conservative Dentistry and Endodontics, and Dr. Mary John, Assistant Professor, Department of Oral Medicine and Radiology, will be the MCs for the day. The academic session will orient you to what to expect for your exams and how to write your final exams. The teaching faculties here are university examiners. Hence, students are encouraged to utilize the opportunity to clarify all their queries on this subject. Since there are numerous students from various colleges, I would like to give a very small intro about our college. Annoor Dental College was born out of the foresight, persistence, and leadership of late Janab T.M. Siti Haji, our founder chairman in the year 2003. It started with the sole aim of imparting quality education in dentistry and also to provide good health and well-being to all sections of the society, as the primary well-being of an individual starts with good oral health. As a research institute, we take pride in its various accomplishments. We have 10 ICMR and 6 Kerala state funded projects. And along with that, four of the undergraduate students are recipients of Tata Trust Scholarship, all for the undergraduates. We have our own scientific journal, AJSR, Annoor Journal of Scientific Research, having successfully published 3 volumes till date, and various training programs on implants, lasers, biopsies, root canal training programs, especially on posterior teeth, all for the undergraduate students are conducted here. We have a fully equipped CBCT center, a tobacco cessation clinic under the name Pratyasha, which runs in association with the Department of Oral Medicine and Radiology, and a zebra fish lab, which runs in association with the Department of Oral Pathology and Microbiology. The hard work and perseverance of Team Annoor has garnered national attention, that we have been ranked 22nd among the private dental colleges in India in a survey by The Week magazine, and also recognized as the College of the Year in 2019 by the Higher Education Review magazine. Another feather to the cap of Annoor. Recently, Annoor Dental College has been accredited with NAC with a grade of B++, highest among standalone dental colleges in Kerala. So now let's have a look at how Annoor Dental College has evolved over the past few years with a short video clip.
History has proven that those who dare to imagine the impossible are the ones who break all the human limitations.
എഡിറ്റ് ചെയ്തതാണോ? അത്ര കളറൊന്നും ഉണ്ടായിരുന്നില്ല.
യസ്യാം സമുദ്ര ഉത സിന്ധുരാവോ യസ്യാമന്നം പൃഷ്ടയഃ സംബഭൂ യസ്യാമിദം ജിൻവതി പ്രാണദേയ सा नो भूमिः पूर्वमे दधातु।
So moving on to today's session, today we have three renowned speakers. Professor Dr. Jiju George Baby, Principal, Annoor Dental College and Hospital, Muvatupuzha. Professor Dr. Deepu George, Head of the Department Oral Pathology and Microbiology. And Professor Dr. Jayanti P. from Assisia Dental College. So if you students have any queries in this talk, you can put it in the chat box and replies will be given after the talk. So introducing the first speaker. Dr. Jiju George Baby is an organized professional with proven teaching, guidance, and counseling skills. He has an experience of 23 years on his resume with strong track record in academics as well as in administration, and currently approved and PhD guide under KUHS University. He has been chairperson in various national PG conferences and PG conventions from 2009 onwards. He has conducted several CPCT hands-on workshops for undergraduates, postgraduates, and general practitioners, with delivering keynote lectures in national and international conferences. He has several index publications to his credit. He speaks with honesty, think with sincerity, and act with integrity. Apart from this, he has been honored with the Best Principal Award of the year 2020. A good teacher, an exemplary administrator, beyond that, an awesome human being. With much happiness, wholeheartedly, I welcome you, sir.
Hope I'm audible.
Yes, sir. Yes, sir.
Sarveshwara Samarambham Shankaracharya Madhyamam Asmatacharya Paryandam Vande Guru Parampara. Tribute to the God Almighty, from where all the wisdom come from. Tribute to all the teachers in the history, and a tribute to all my teachers and all the teachers around. Happy Teachers Day to you all. So first, let me thank and Dr. Sinju Paul, for a wonderful introduction. Hope I live up to your expectations. Okay, so just coming to our today's topic. See, you talk about a person, and any professional for that matter, whether he's a like advocate, he's a teacher or academician, whatever you doctor, whatever it is, the first thing everybody notices in somebody is going to be the confidence. I'm just talking about a person who like exemplified with his confidence to the entire world. You know that cricket is everywhere in India, especially it is there in our blood. And I'm just going to talk to a person, a cricketer, who has shown himself to the world that he is a confident being and he can light up the beliefs and dreams of a nation. And World Cup final in India, India playing against Sri Lanka and batting second, India lost 3 wickets. And a person promoted himself above the informed Yuvraj Singh, none other than our previous captain, Mahendra Singh Dhoni. Just see the confidence by which he comes to the pitch. There are 3 people who transformed Indian cricket. The first one, Sourav Ganguly. Second one, Mahendra Singh Dhoni. Third one, Virat Kohli. All these 3 people had talents in their team, but most successful till date is Mahendra Singh Dhoni. You know why? The difference which he exhibited, more than aggression, he exhibited his confidence. From where the confidence came from, it's from experience and experience through practice. Most importantly, he had a composed mind, cool mindset. That's why he could deliver, he could take decisions that change the history of Indian cricket. So coming to today's topic, Alistair, prepare yourself, not only for the examination, as a professional, how to prepare yourself. So we understood that preparation is going to be the key. I will just go to a story of Pandavas and Kauravas. It's an epic story also, the epic story of India. See, Pandavas and Kauravas in the early age, they were really thick friends. They were brothers and they were thick friends. They joined the Gurukul of Drona on the same day. And it was a Gurukul system of traditional Indian education. Means to say that everybody just goes to Guru's place and they live there. And early morning, they have to get up. They have to help a Guru Bhakti in the household activities and they did everything together. I mean to say that studied together, martial arts together, eat it together, and finally slept also together. One day, what happened was, see, Bhima was sitting next to the Arjuna. So it was in the night, it was dinner time. So everybody having the dinner. So that time, the current was not there. The only oil lamps used to be there for the light. So current went off. The wind blew and light flickered and the light died off. So what happened was everybody stopped eating, but the voracious foodie Bhima was still eating. Just this triggered Arjuna's mind because he knew that if he knew the target, definitely you can hit. So that day onward, he started practicing in the night. And night, everybody is supposed to sleep. The Guru, Drona heard the sound, something is happening outside. Went out and saw his student, the disciple, is practicing in the darkness. So he asked him, what is this? Then he explained entire scenario. Just seeing his commitment and hard work, this Arjuna became Drona's best student. You know what is history? Still today, even though it is an epic, he is regarded as the best warrior in the history. That's a preparation, that's a hard work, that's a dedication, and so that's a loyalty towards the teachers also. So preparation is an year-long process. One day, 2 days, it is not to happen. The famous quote goes like this: Rome was not built in a day. Now, today's topic, we will discuss in 4 headings. The first is preparation. Second is how to write. Third, your food habits. And most importantly, fourth one, your mindset. So coming to early preparations. See, please, whenever you are studying, okay, this is the fag and I know 3rd year, but still one thing I tell you. See, when you study a subject, you study a subject as a whole. You need this subject for the entire life. If you are practicing this profession, you need it for entire life. With that bigger perspective, you have to look into the subject. I'm an oral medicine man. Even oral pathology is a fantastic science. See, it gives all around idea about the entire dentistry. When you have the knowledge, you have the confidence. When you talk to the people, especially the patients, patient look at your face for the confidence. Then, if a student's life is complete, definitely there should be a schedule. The first thing is that he has to get up early. My father gets up at 4 a.m. in the morning, but my father 6:30. Everybody, almost 90% of the students are nowadays staying in the campus. You can get up at 6:30, finish your all the programs by 7:30 minutes. You can do that little bit stretching exercises and just find 15 minutes time to study the classes which has taken on the previous class. Just go through the notes. Then definitely go to the college, go to the clinics or preclinical labs, finish all the things, have lunch, have an afternoon nap, then go for a recreation, some sort of recreation, any physical activity for that matter. You can walk also. If you are interested in playing, you can walk also. Music, dance, anything you can go. Daily, at least 1 hour, definitely, you should be engaged to a recreational activities. Go back, take bath, then go to the library. Library is a fantastic place. 1 to 2 hours, minimum 1 hour, 5 days a week, enough. Dentistry is finished. You will learn all the art and science of dentistry within an hour if you spend 1 day. So only thing is that 1 hour per day. So one thing, if you are concentrating, 1 hour is enough. So if you are a slow learner, it may go up to 2 hours. So instead of studying for the examiners, kindly spread it out. That increases your brain. That increases your confidence also. So spread it out. And more important part is going to be, you should have a goal. You should live for a goal also. And goals should change. Third year, you should be having one goal. Okay, third year is almost over. Now, only aim left to you is that to perform well in the examination. We will tell you how it is. The second thing is that, now understand one thing. See, every year, many of the institutions or colleges or different organizations conduct essay competitions. They have paper presentation competitions. They have all the other competitions in the world. If you are capable, please participate. All these accolades adds your performa, adds your curriculum vitae that will give you. So if you have utilized well, you'll have at minimum 10 prizes before you pass out. You can go for publications. We forget about international, at least you can have national publications. All those stuffs you should have. So goals must be specific. It must be measurable, must be realistic, and has to be time specific also. So coming to the studies, first is the organize the time, the materials. For that, you should create a study timeline. Why academics become boring? You know that? Because it is drag. See, if you fix a question, and I say question, you fix a time. Say, I can study within 30 minutes or 45 minutes. Depends on caliber. Fix the time, concentrate on that time, and finish within that time. See, that means by the 2 hours you finish, you will be finishing 2 or 3 questions. So the volume is moved. You study 10 questions per day, that's enough. So mean to say that 4 to 5 hours, if you study, if you can easily finish 10 questions, that will cover the entire syllabus. And when you study the questions, prioritize the questions. The first important ones first, then like that you have to go. And always think of evaluator's side also. Evaluator's key point to be noticed. Create your own study materials. You know, as far as oral pathology is concerned, we have got fabulous teachers in Kerala. I can count up to 36 very good teachers, 36 very good teachers in Kerala. Every college will have 2 very good teachers with respect to all. At least one great teacher will be there in oral pathology in all the colleges. Mean to say that they will be giving you notes. Either they will be giving printed notes or they will give you the lecture notes also. But one thing I tell you, this lecture notes won't be complete. It will cover only 80%. Leave a page, same day go to the library, complete this. Just see in the picture, just complete this. Underline, hyphen, whatever you want to do, important points. So you have your own study material. One thing I tell you, see, I've seen my interns studying for the entrance examination. They're sitting with big books because they don't have notes. See, notes means I don't tell you not to not 100% rely on the notes alone. Notes must be complete with the help of library. If you have a note of your own handwriting, see, when you prepare for a PG examination, it will be quite easy for you. You will be able to finish the reading of the entire chapter within minutes because it is your own notes. It is a complete note also. When you make notes, make chapter-wise notes, and you have to refer the important textbook also, and always highlight the important notes in your notebook. You can use the technology. Nowadays, everything is available in the net. Informative videos, your lymph node palpation, whatever you want, it's available. And you have got audio playbooks, you have got ebooks. And whenever you take topics for presentations as well as seminars, you take an exam-oriented question. So mean to say that when you present something, you will never forget. An essay question you take, you will never forget. That will be there with you. Otherwise, in all your phones, you have got recording capacity. So you have learned a topic and you have by hearted it and just on the record and you say. So after some time, if you forget it, just on, you can hear it in your own voice also. So use the technology for the betterment. And coming to the campus resources, campus is the best place in life. The best place like time in a student's period, the first school days, that's over. Now it's a campus, UG life. Campus is wonderful if you use it wisely. The first thing is that library. Just go to the library. If you are not interested in medical books, you can, the other books and the things are available in the library. Just go read them. You will find people. You will try to interact with people. You get good relations from library also. But be time specific. Just go for 1 hour, then just 60 minutes. You are not attend any mobile, and you have to. You should not be distracted. You should not be talking to anybody other than the subject. If you finish every day's topic then and there itself, definitely you will be having finished material with you. Okay. The second thing is that you have to choose a recreation. Let it be sports, let it be arts, anything. Otherwise, you can just walk also. 1 hour, you must have a recreational activity every day. The last point is that health advices. See, advices you can take from two people, one from a staff member, second from seniors. With all due respect, seniors, I find 3 type people. The first thing is that very studious, academically brilliant people. Hardly they help others. Hardly they help others. The second one, see, they are not bothered. Hey, what to do, man? Hey, nothing else. The last variety is, again, they'll disappoint you. What a twist. Don't do this. You'll study for the examination. Come, enjoy. These are the 3 kind of candidates. But few people are there. Few seniors are there to really help you. Find those kind of people. Just keep them as your mentors. And the second thing is staff mentorship. When you choose a staff member, nowadays most of the college gives staff mentors. But when you choose a staff member, you should make sure that he is successful in his profession. He should be having a positive attitude. And definitely you should have a feeling that you should come up. And mentoring really means that the mentee should come up above the mentor. If that person is having that caliber, that attitude, choose him, keep him for his life, because that will help you to come up in your profession, not only in profession, in personal way also. So now, I usually hear one question or maybe one hilarious or exclamations. What I see is that if it is an easy question paper, sir, we didn't get time. We couldn't write last 3 questions. And if it is a difficult question paper, gone. It's full cry only. Okay. See, what is the difference between an easy question paper where you have missed 3 questions and a difficult question paper? So if you want to have that slight time allotment, you should be experienced in writing examination. So the laziness is the only one thing which prevents you from. Okay, fine. If you can't allot 3 hours in a test, you can divide it. Mean to say that 2 essays you can write in 1 hour. 4 short notes. Again, the second day you can write 4 short essays again in 1 hour. And the third day, again, you can write 10 short notes in 1 hour. Mean to say that you are supposed to take 30 minutes for long essays, 15 minutes for short essays, and 6 minutes for short notes. This is the time distribution. And even if you know the subject, if you are not experienced in writing examination, you won't be able to finish. So studying and practice is the most important part. You know one thing, I've just gone through the previous 3 years question paper. 70% of the questions are repeated. You take last 6 question papers, 3 years, regular and supplementary, 70% of the questions are repeated. You are talking about all year preparations. It's gone. Now we have got only 54 days left for the examination. What to do? Tell you. Again, if you follow this, 60% is guaranteed. This is the short time preparation. This question bank I prepared by consulting 4 excellent academicians from the different colleges. So I have marked 75 questions. 75 questions. Means to say that if you go study 11 questions per day, 2 essays, 2 short essays, and 4 short notes every day, for 7 days, you will be getting minimum 60% mark. 52 mark from you get all these 70, 75 questions. If you are talking about premalignant lesions and epithelial tumors, the most common is going to be oral squamous cell carcinoma, leukoplakia, and oisoma. If somebody wants to take a screenshot, please take it. It is from different teachers and after taken from consulting with the different teachers. Okay, all these questions 75 only. Mean to say that 11 questions per day. If you study, definitely in 7 days, you will finish oral pathology with 60% marks. And most important, this one, again, take a screenshot. Then one thing I tell you, there is something known as forensic odontology here. There is only mainly 4 questions: lip prints, bite marks, age estimation, and rugoscopy. Out of these 4 questions, 2 questions are going to come. DNA probing is also coming in age estimation. So out of this 4 questions, you are going to get 2 short notes. So mean to say, if you study 4, today itself, you are going to get short is 2. So kindly take a screenshot and keep it with you. 75 questions, 70%, definitely 50 marks, definitely I will come out of it. And to score 60%, it's going to be very easy. I've just get the proof. I've referred last 4 question papers, not this year's, last 2 years question, that 4 question papers, whatever marks is from this question bank only. Now, the scheme of the examination. The first thing is that usually 90% of the times, 2 essays from oral pathology only. And short essay, usually 1 question comes from microbiology. And the last important part is going to be forensic odontology. You have 2 questions as per syllabus. 1 for sure, 2 questions as per syllabus. Now, group study. See, if you can't concentrate, if you are sitting there studying alone, if you can't concentrate, you have to go for group studies. Only thing is that that group must be disciplined. And you should have a time schedule. That means to say that you are going to finish this question from this time to this time onwards, not talking in between. This group studies, I tell you something. See, you study something and you teach your best friend. So definitely you are going to earn more, learn more. Why I tell you, knowledge is from heaven. It is free for everyone. It increases by sharing. It will increase by sharing. It will never reduce by sharing. One thing I tell you, even if you teach somebody 100%, that person, he can't be learned from you. So again, 80% only goes, definitely mark will be less. And for you, after repeating, when you teach someone, definitely your knowledge, your confidence is going to increase. And only thing is that more than that, it will increase the positive vibe, the friendship line, again, it will increase. I had a study mate, definitely we will help each other. Now today we are still best friends, even if after 25 years also. One thing I tell you, see, if I want to learn something, I'll take a class. When I take a class, I'll refer each and every material, each and every journal available, and I'll prepare myself in such a way that it is comprehensive. When I take a class, it will be a comprehensive class. I will never forget. It will be the same way. It will be the same way for you also. When you teach someone, when you tell someone, see, you have 101 jokes around, definitely you can just say the definition of ameloblastoma, OKC, and all those stuff, classification of cyst, classification of ameloblastoma, everything you can say. It will, as you repeat, definitely just sticks your mind quite frequently also. And you have 101 games. You play Antakshari. Same way you can play with the, academics also. While studies, you can use all these technologies. Outlining you can do, bootlegs you can do, spider diagrams, wall stickings, anything you want to, which are frequent. Only thing is that it should stick to your mind so that you remember. Okay. And 1 hour you study or 2 hours you study. Take a small break. Do a little bit stretching exercise, walk for some time, and try to remember what you have learned. So after some time, you know that, okay, I have lost that. Okay, just go back, read again, just walk. So with the physical activity increases your blood circulation, definitely it will give you a break also. Whether it's a long term or short term, you have done your work. Now, most important part is going to be how to write. You have learned everything, but if you don't know to write, you have lost. It is simple. It is just logical. It is the common sense, I tell you. See, when you go to a paper, you should know that. See, an evaluator usually evaluate, due respect to all the evaluators, usually what happens that evaluation starts at 10 and finishes by 4. Mean to say that you have got 6 hours. 6 hours, an evaluator evaluates 45 papers. Mean to say that every 2 hours, he evaluates 15. Every hour, 7 to 8. 40 pages average per paper, mean to say that an evaluator is going to spend in your 1-page answer for 8 to 12 seconds. Whom will you blame? Will you blame the system or will you blame yourself? 8 to 10 seconds. Forget it. 15 seconds per page. You have studied for the entire year, and the person is going to look at your paper only for 15 seconds. Then what you should do? Definitely, you should pile up your answers and you should project your answers such a way that definitely the evaluator is going to see. See, 9:20, the question paper will be given to you. You can plan your answers. 9:30 sharp, you start. Always write the number outside the margin, main numbers outside the margin. Write the title. For essay question, write the contents. Why I tell you this is important? If I am the evaluator, definitely I go through each content. So I have seen everything is there in the content. Do you think I'm going to read the entire papers you have written? No. So content itself reveals the attitude of a student. Coming to second thing, if you're writing a classification, whose classification? Underline with a red pen. The red pen only used for underlining. You can use boxes or whatever you want, you can use it, but always do it with the red pen only. And then most importantly, diagrams. If the question demands a diagram, draw it legibly in the beginning of the answer itself and label it properly. If it is done, I don't think many of the examiners is going to read through the entire paper. So that's itself shows the attitude, the caliber of a student. And especially before that, then if you stop one answer at one point, definitely leave 2-3 lines, then you start the next one. Otherwise, it will be difficult. Always number outside the margins. I've seen many people coming to the examination halls very lazy and yawning and some are sleeping also. Maybe depending on your habit. You may be getting up early in the morning, might have not slept, whatever it is. But if you are sleeping, okay, for me, I used to study till 2 a.m., then sleep for 4 hours, get up at 6 a.m. Then what I do is that I drink, 500 to 1 liter of water. You need water. Then do a slight stretching exercise. All your responsibilities are over. Then take a spoon of honey. There are foods which are known as brain foods. The honey is supposed to be excellent for the brain. So what happens is that, see, honey releases increased levels of dopamine and serotonin. Dopamine is an excellent neurotransmitter, and serotonin definitely controls your moods. It controls the wellness. So if you have got increased secretion of serotonin and dopamine, definitely your brain will be active. 70% of the body is constituted of water. So you have you hydrated yourself by 6:30. If you drink, definitely 1.5 hours, it is flushed out. Body is hydrated. Only topping is required. You take 1 spoon of honey early in the morning. Quality of honey is your problem. Make sure that you get good honey and have good honey. Have very little food. If you're taking only 2 idlis, dosas and 1 glass of milk, that's enough. You have to be, stomach should not be empty. Only thing is that maybe less than half, that is the best. Then last one is going to be chocolates. I'm not talking about small time chocolate, good chocolates, Cadbury's or etc. Or maybe higher version chocolates. This Cadbury's, the chocolates also releases dopamine. So this activates your brain. So the memory is alive. Only thing is that if you have a little bit stretching exercise also, your blood circulation is going to be all right. Definitely you will be vibrant in the examination hall. And there are 4 types of food which is totally contraindicated. The first is tapioca or kappa, then potatoes, ginger, and your chilies. All these reduces our serotonin level, the feeling of wellness level. Malayalam, a famous saying goes like this, So the mean to say that you'll be highly irritant. So you'll be disoriented. You won't be able to concentrate. During the examination and the study holidays time, don't use these 4 kinds of food because that reduces your serotonin level. The last one is going to be mental attitude. See, please mind you, excellent student, done all the hard work, very good handwriting, everything is there. While coming down, if the mental attitude is not right, if you are really tense and scared, you are not going to finish. If you have done your work, if you are prepared well, if you know everything, then why should you worry? See, if Virat Kohli sits in the dugout Do you think he'll get all the records? No. It is our playing field. Definitely, we have to come out and bat. And when you have this much, long term, excellent. Short term, very good. Still 60% is guaranteed. You see, in the transaction analysis, what I've learned is that everybody needs like stocks, positive stocks. Every day you need at least 2,000 positive stocks. That comes from naturally. So always visualize the life positively. You have to score. You have to score yourself and always have a positive affirmation and take the advantage of taking exam. Without taking exam, you can't go. So definitely we have to face it. When you know it, what is wrong, just face it. And revision is the key. When you revise the more, definitely it just sticks to your head. And positive attitude, brain foods, and how to write and prepared well, you have done. Last one is going to be the prayer. You might be an atheist, you might be a believer also, but we all know that there is a power above us, controls the entire universe, and that is known as God, Brahman, Allah, whoever it is. And the God resides in your heart. God means goodness resides in your heart. And you have to talk to yourself. And you are the best being in the universe and you can talk to. But what you talk is your responsibility. If you have positive stocks, if you are affirming yourself positively, you can do it. Means one day you will be successful. Every day, find little time to talk to yourself, talk to God, be in peace so that you motivate yourself. One of the speech gurus, T.T. Rangarajan, has given a wonderful explanation what God thinks about you, what God thinks about a studying student or maybe a professional. Just listen to it.
Let's work like nobody has seen. Let the world beat us on intelligence. Let the world beat us on IQ. Let the world beat us on competence. Let the world beat us on communication. Let the world beat us on anything. Let the world not beat us on competent effort. Let our effort outbeat everybody else in the world. There is one thing that we will not spare. We are not going to find anybody in our department who can put in more competent effort than us. In our organization, nobody is going to deliver more competent effort than us. Let's go ahead. I know it is a very comical reference, but I wish to believe so. In the entire Kurukshetra, Krishna could have been with anybody, but somehow he conspired the entire circumstances and ensured he was with Arjuna. That was the reason. I wish to believe so. In the entire Kurukshetra, Arjuna was the best warrior. Krishna felt safe being with him. If I have to be in a battlefield, let me be next to the best Kshatriya who is there. So I think Vedavyas is delivering an unspoken message to you and me. He says, if you want God with you, first you got to be the best in what you do. You got to be the best in what you do. I'll put it this way. If you're not the best, you seek God. If you are the best in what you do, God seeks you. He wants to be with you. If you do your best, He will do the rest. If you don't do your best, He will take rest.
In Annoor, we have done this much. We have given the 100% competent effort. We are very simple beings, very humble beings, ordinary people. But effort which was given was 100%. That's why this much accolades have come. And we worked as a team also. We complement each other. My dear children, you are young. You are really good. I have never seen a bad student. Exemplary, excellent students, very good student, average or average plus students. I have never seen a bad student. If somebody is bad, that is because of their attitude, nothing else. Myself and the legendary Dr. Varghese Mani has done a study, and we have learned that if somebody has scored 70% in CBSE or 80% in Kerala state syllabus, you can't fail. You can't fail. If you're failing, only one reason, your attitude. Your strategy is not right or your attitude is not right. Correct it. See, it's not only the examination, the entire life is ahead of you. You have to perform. As a family person, you have to perform. As a father, mother, everything you have to perform. As a professional, as a social being, everywhere you have to perform. The society looks at your sincerity. Excellence means it is not the best in the world. Excellence means if you are giving 100%, you are excellent. You are excellent and my excellence is totally different. If you are giving 100%, that is your excellence. Whom will you stand with? Whom will you stand with? Even if you are not best in the world, You will start with an excellent person. He is 100% sincere. He is giving 100% effort. God blesses those two people only. So, my dear children, we will summarize this today's topic. So every day, see, this will guarantee you minimum 60%. Don't think of passing. Just try to perform the best you can. Easy, man. Very easy. 75 questions in a simple strategy. 7 days. Oral pathology 60% guarantee. Provided you have the correct answers with you. Even if you have the study, don't have the study material right away, just copy it. Take a Xerox. Ask your teachers. Definitely they will be having it. Just keep it with you. Only thing is just run through it, then study. 7 days, 11 questions each, 75. Done. Okay. Now we'll just summarize. Okay. Every day. Part 1 onwards, every day, 1-2 hours per day. Use the library campus resources. And always you must have goals. Goals in the sense, during academics, you should keep, I should score this much marks. I should do this essay competition, this conference I should attend. I should present this paper. I should have this publication. And the credentials matters. When you come out, go for an interview. Whether it's a foreign country or national, any agency, everybody asks about the publications. What all the other extracurricular activities you have, what are the other talents other than the subject you have, then please write your own notes. Everywhere there's competitive examination, your PG, your diplomas, your abroad, your MOH, anywhere, your defense, anywhere you go, you got competitive examination. If you start studying from the first chapter onwards, anatomy, it will take 2-3 years. But if you have completed notes with you, it's going to be easy with you. Forget out the subject which has passed. Now, 8 clinical subject, 8 plus 1, 9. Oral pathology is still there. So the rest you can manage. But this, if you can make the notes and keep it with you, completed notes, class notes plus library notes. Please go for a syllabus evaluation before the beginning of year. Use the technology wisely. Campus. Use the campus. This is the best time in your life. Use it. And previous year's question paper to be evaluated. And maybe in modules also, you should practice. And always mind you, 70 to 75 questions are repeated. Encourage group studies. Teach your friends. You learn more. And how to present examination paper. Start from now. Definitely you will do wonders. One thing which I forgot to tell you is that always start with essays. Please don't start with short notes. Essays first, short essays second, and last is short notes. Because if you write the other way around, minimum 5 marks difference will be there. Minimum 5 marks difference is going to be there. And food is really important. Food is really important. Don't stock your food stomach with your food. Minimum 50%, maximum up to 75%, not more than that. 4 foods are contraindicated. But during studies, take honey in the morning, and during examination, take chocolate. You can carry chocolates. Only thing is that you are not supposed to carry wrapper into the examination hall. Just 8:30, just put one in the mouth, let it be, let it evolve through the saliva, just goes in. And then 10:30 again, you can have 11:30 again, you can one more. Again, it will remain in the mouth. Definitely your dopamine and serotonin levels will be high. Your brain will be working really good. And finally, prayer. Let God Almighty help you in each and everything. Always give positive strokes to your heart so that you are a wonderful being, positive being. Everybody likes to be with you. Every employer would like to have you. The last is positive attitude. And the history is created by people with positive attitudes. Thank you. All the very best.
Thank you, Jiju sir, for the brainstorming session. Now, actually, we have one query in the chat box to share the important repeated questions one more time. I think due to short of time.
No, that will be shared. That will be shared in the WhatsApp group. That will be shared in the WhatsApp
yes, definitely.
group. Today evening itself, it will be shared in the WhatsApp group. Okay, please, any references, any queries, you can just contact Annoor College. They will connect to me or any other staff. Anytime you are welcome. Whichever colleges you are in, no problem. Thank you.
Thank you, sir. Now we'll be moving to the next session shortly.
That was an energizing kickstart for the day. Once again, thank you, Jiju sir. And we will be moving on to another interesting session on dermatopathology by Dr. Deebu George Matthew. Introducing the speaker, Dr. Deebu George Matthew completed his BDS and MDS from Dr. MGR University, currently working as professor and head in Annoor Dental College and Hospital in the Department of Oral Pathology and Microbiology. And he is the founder, partner, and supervising oral pathologist of Nirnaya Orofacial Diagnostics, which is an exclusive oral pathology diagnostic service since 2016. He is very much into research practice in the field of oral pathology, which include lymphocyte culture, cytogenetics, zebrafish human equivalent researches, tissue engineering, and many more. He has several indexed publications to his credit and has been invited as guest speaker in various forums. He has been honored with various awards for his exemplary work in oral pathology. Sir, we are so privileged to have you here today. Wholeheartedly, I welcome you, sir.
So, am I audible?
Yes,
Am I
sir.
audible?
Yes, sir.
So, good morning to you all. It's been a pleasant day, a very auspicious day, because today is Teachers' Day. The morning I got some mails, like, messages, then only I realized it's a Teachers' Day. So I feel like it is a very auspicious day for starting a program, a teaching program like this, when it is a teaching, a teaching program, like especially on a Teachers' Day. So with this, let me start the presentation. And thank you so much, Jess, for this kind introduction. And so let us start with the presentation for today. So today what we're going to talk about is dermatopathology, or the skin pathologies. One of the most important topics that when we teach in oral pathology third year. So very often, when we talk to students about appearing for exams, we find that they find that it's pretty easy for them when it is being taught in the class. But at the time when they come for the exams, they say that it all gets confused with one another, and they're not able to recollect the things. So the reason why I feel the reason why they have a problem like this, especially at the time of exam, is they don't understand and learn. They don't understand the concepts and learn the things. So if you are able to understand the pathogenesis, or the etiopathogenesis of each disease, it becomes very easy to understand why the clinical features are coming and why the histology is coming and what is the reason why we give that particular kind of drug for treating these diseases. So in the end, it is not about just passing your ORPAT exam. It's more than that. It's about equipping yourself to do a proper practice. So with this, let me start with the dermatopathology chapter, or the skin chapter. Now, we know that such a vast topic, it's not possible for me to deal with all the questions. But as Dr. Diju sir was saying, the previous session, most of these questions are repeated again and again. That's because it's not because people are lazy to put more new questions. It's because those are the very, very important things that an undergraduate is supposed to know before they start doing their practice. Then once they see these things in the patient's oral cavity, they should be able to make a diagnosis. At least they should have a suspicion that about that particular clinical situation, and they should be ready to call a specialist or do a biopsy and do the further management. So that is the reason why these questions are always being repeated. So as I told you, today is a Teachers' Day. So the blessings of the teachers are very important. So I dedicate this particular session to my teachers, Dr. T.R. Saraswati and Dr. K. Ranganathan. Because of them, academically, I am here where I am now is because of the guidance and the motivation that they have given to me. Now, if you talk about the question, that is usually comes for your exams, we know that we have 2 essay questions, 10 marks each, and 4 short notes are there, 5 marks each. This is how they name the this question categories in your question paper, and 10 brief notes are there with 3 marks each. So the total time that you can spend for an essay is maximum 25 to 30 minutes. If you go beyond that, and if you keep writing the exam for 45 minutes and things like that, in the end, you're going to lose time to write 3 brief notes or 3 marks questions. And losing three marks questions means you're going to lose 9 marks out of it, just like you were losing an essay question. So there is a high probability that you may not be able to pass the exam if you're going to make stupid mistakes like that. So you have to be very careful in your time management. So what you need to do is you have to prepare for your, even if you have learned the theory, you have to be prepared on what all are the headings under which I'm going to write the exam or write the essay which is going to come. That you have to keep planning, and you have to be planned before you go for the exam. That's very important. Okay. So the maximum time that you can spend for an essay is 10 marks. Is around 30 minutes. And for a short note, 5 marks question, you can spend maximum of 15 minutes. Beyond that, if you spend, you're going to sacrifice the time that you can spend for a 3 marks question. So 3 marks, maximum time you can give is around 5 to 6 minutes, not beyond that. Okay. So with this thing in your head, mind, let us go to the next part. So what are the commonly asked? I'm going to focus more on the essay questions that's been commonly asked in the skin chapter. So the usually 2 questions are being commonly asked in the skin chapter. One is classify vesiculobullous lesions and discuss in detail pemphigus vulgaris. So one of the most commonly asked question in this particular category. The other question that has been commonly asked is classify skin diseases and discuss etiology, clinical features, and histopathology of lichen planus. So if you can prepare yourself now, about the headings under which you're going to write it, and what are the points that you're going to underline when you're writing an essay on these topics, I think it will become much more easier for you, to face the exams. Okay. Now, the other questions that usually been asked is about erythema multiforme, scleroderma, systemic lupus erythematosus, and mucous membrane pemphigoid or cicatricial pemphigoid. So these are the other common short essay questions, or 5 marks questions that has been usually asked. And all these small pointers like Nikolsky sign, Auspitz signs, and these are the small 3 marks questions that has been Sang cells. So these are the things that has been commonly asked in the case of 3 marks questions, when it comes to the skin pathology. So most of the times it has been repeated again and again. That doesn't mean that is the only things that you have to learn. But if you have learned at least this much, you are at least prepared, to a certain extent to face the exams. So let me start with first the classify this first question. Let us go with the first question, that is the classify vesiculobullous lesions and discuss in detail the pemphigus vulgaris. So before going into that, you should have some idea, some background knowledge about few terminologies and few of the disease process or the pathogenesis processes that occurs in these diseases, or you need to have some kind of an understanding about it. So the way I'm going to go about with this particular session is, first I'm going to teach you about the disease a little bit. Then I'm going to show you how to frame an answer for it when you're going to write an exam. Okay, so how to frame an answer for these kind of essay questions. So first one, the question that we have to have an idea is, what do you really mean by a vesicle and a bullae? What is autoimmunity? What is a desmosome? These are the things that you already know. I just want to brush up your memory so that it will become much more easier for you to recognize or understand these things. And what is a hemidesmosome? What is an immunofluorescence assays? So these are the things that we're going to see very fast. So the vesicle is actually what we call as a vesicle is a superficial fluid-filled blister with a size less than or equal to 5 millimeter. If the size is more than 5 millimeter, we'll call it as a bullae. So all those lesions where we have this fluid-filled blisters, we are going to call it as vesiculobullous lesions. And most of these vesiculobullous lesions are caused by autoimmunity. Now, what is autoimmunity? Autoimmunity is, that the immune reaction is supposed to help us from bacteria and viral organisms which are coming from outside. But sometimes what will happen is that this immune mechanism can attack our own tissues. So this kind of a scenario is known as autoimmunity. That is the immune reaction mounted against body's own tissues. Okay, so it can be because of autoreactive lymphocytes or autoantibodies produced by the autoreactive B lymphocytes, and they attack body's own tissues. And 2 of the main important diseases that we learn in skin pathology, that is pemphigus and pemphigoid, are both autoimmune disorders. And even lichen planus is also an autoimmune disorder. In the case of pemphigus, the desmosomal proteins that forms the cell-to-cell junctions are being targeted, while in pemphigoid, the hemidesmosomal junctions, that is the attachment of the basal layer cells to the basement membrane. That part is being targeted in the case of a pemphigoid. Now let's talk about what is a desmosome. As you can see in the pictorial representation here, there are two cells here, and the cells, especially the epithelial cells, they are attached to one another. There is no space between the cells, and these cells are attached to one another by means of a complex, a protein complex known as desmosome. So the desmosome has got three types of proteins in it. The first one is a transmembrane adhesion protein, that is like through and through the cell membrane you have this protein going. So that is called the transmembrane adhesion protein. That is the one that actually connects the two cells between one another. Then we have another set of proteins known as cytoplasmic anchoring proteins, and anchored to these cytoplasmic anchoring proteins, we have keratin filaments. And this is how the desmosomal junctions are organized. So you don't have to worry too much about this. This is just for your understanding. So the transmembrane protein that is there in the epithelium is there. The names are desmoglein and desmocholine. Anchoring proteins are desmoplakin, placoglobulin, and cytoskeletal proteins are keratin filaments. Okay, so this desmoglein is very important for us when we are going to learn about pemphigus. So that is why we are talking about desmosomes now. Okay, so there are different types of desmoglein molecules, desmoglein 1, desmoglein 3, desmoglein 2, and all are there. So this you have to keep it in your mind when we are going to deal with pemphigus. Now, when it comes to hemidesmosomes, it is about the attachment of the basal cells to the basement membrane. So here the molecules are, again, we have a transmembrane protein here, but that transmembrane protein is called BP180 and alpha 6 beta for integrin. Okay, and this transmembrane protein facilitates the attachment of the basal cells onto the basement membrane. Okay, then again we have anchoring proteins, cytoplasmic anchoring proteins within the cell, that is formed by BP230 and plectin. Then anchored to that we have the keratin filaments. So if a autoimmune reaction is being elicited or like it's been formed against any of these hemidesmosomal proteins, what will happen? The epithelium will get detached from the underlying basement membrane. So that is how pemphigoid occurs. Okay, so all of you now have an idea about like why we are discussing about desmosomes and hemidesmosomes. I don't think it's very difficult. It is a pretty easy thing. Okay, so another important factor that you have to remember is about the overview of the immune factors. So sometimes when you read through the text, like you will find MHC proteins and HLA genes and stuff like that. So you don't have to worry too much about it. It's very simple. Now, what you need to remember is there are certain genes in chromosome number 6 known as HLA genes or human histocompatibility genes. And the product of this gene is a protein. This protein is known as MHC protein, major histocompatibility protein. Okay, and these proteins are present on the surface of the cells. Okay, and what is the function of these MHC proteins? These MHC proteins are present in certain type of cells known as antigen presenting cells. I just want to take your memory back to the time when you have done your oral histology classes. You would have learned about non-keratinocytes. There were 4 non-keratinocytes. Out of that, one of the non-keratinocytes was Langerhans cells. And what was a Langerhans cell? It was an antigen presenting cell present in the epithelium. Okay, and what is its function? If some kind of a bacteria or something enters through the skin, it engulfs the bacteria, breaks them down into small products, and they will have this protein on the surface. That is the MHC protein, the red one that is just now appeared. Okay, and onto that MHC protein, this broken down bacterial proteins will be presented on the top of that, like as if like it has been put on a plate and it's been presented to somebody else. To whom are we presenting it? The antigen, like, you know, this, what do you call, the bacterial antigens are being presented to whom? It is presented to a helper T lymphocyte. Okay, once the helper T lymphocyte recognizes this antigen presenter on the MHC of an antigen presenting cell, what will they do? They will induce the B lymphocytes to produce antibodies. Okay, and this antibody goes and attacks the other bacteria, which has got the similar protein that has been presented, and they will kill the bacteria. This is how usually the immunity works in our body. But sometimes what will happen is the MHC will not work properly. The antigen presenting cells will not work properly. What will they do? Instead of presenting the foreign antigens to the T lymphocyte, what they will do? They will present the body's own proteins. Our own cells are being presented, okay, and to the T lymphocyte. So they present the our own tissue, our own antigens or protein, that is called self-antigens. That has been presented, and autoreactive T lymphocyte. The T lymphocyte is not supposed to attack us, but sometimes in certain people, in certain conditions, they may have autoreactive T lymphocyte, which are programmed to attack our own cells. Okay, and they activate, induce B cell antibody production, and autoantibodies are being formed. These autoantibodies will attack our own tissues and destroy the tissues, and this is how an autoimmune disease is occurring. So all of you are now clear about desmosomes, hemidesmosomes. Now you are also aware about like how immune reaction is working and how autoimmunity is working. Now, two more things, investigations that you have to remember when you are talking about vesiculobullous lesions is direct immunofluorescence. In direct immunofluorescence, what we do is we take a biopsy from the area. This is actually an adjuvant technique that we use along with histopathology in order to detect the presence of autoantibodies in the tissue, in the tissues. So here what we do is we take the patient's tissue, we put commercially available antibodies against autoantibodies, because we are trying to see the presence of autoantibodies. So we have commercially available fluorescent tagged antibodies are there, which are marked against the autoantibodies. We will put that on the top of the tissues. We will wash it. And if the autoantibodies are present on the tissues, these fluorescent tagged antibodies will stick onto that, and you will be able to visualize it. You will be able to visualize it in your fluorescent microscope. You'll be able to visualize it in your fluorescent microscope. And then by that, you'll be able to see where the autoantibodies are located. But sometimes what happens is sometimes the lesions will start in the oral cavity and may not be there in any of the skin area. But the clinician will be worried, like in later, like what if it spreads into the skin also? So in order to know that, like if that is possible to become a systemic change, you have to see the presence of autoantibodies in the serum of the patient, in the blood of the patient. So the serum of the patient is taken, it is being put on a monkey's esophagus. Okay, so if the autoantibodies are present in the serum, then like the autoantibodies will stick on to the tissues of that is there in the monkey's esophagus. Okay, then we will wash it. Then again, we will apply a fluorescent tagged commercially available antibody against autoantibody. Okay, if in the serum that autoantibody was present, it would have stuck onto that monkey's esophagus tissue. Okay, and when you are putting the fluorescent tagged antibody against the autoantibody, that will stick onto that. And when you're seeing it under the fluorescent microscope, you'll be able to visualize it. So this is how you usually see. You can see here the immunofluorescent slides. You can see how the desmosomal junctions are being illuminated in the fluorescent microscope. This is a case of pemphigus. And there's an indirect immunofluorescence. Both of them will show the same kind of appearance. So these are the things that you have to remember before we start with pemphigus. So this kind of a background knowledge is necessary when we talk about pemphigus. Now, this is the question that usually comes in your as an essay. So classify vesiculobullous lesions and discuss in detail pemphigus vulgaris. So first, let's talk about how we are going to classify vesiculobullous lesion. There are two ways in which you can classify vesiculobullous lesion. So whenever we start with classification, you should always mention about what is the premise of the classification, or based on what you are going to classify the particular diseases. So here, the first way in which you can classify is based on the pathogenesis. So based on that, we can classify them under three categories: autoimmune vesiculobullous lesions, infective, like vesiculobullous lesions occurring as a result of infections or because of some kind of a hereditary problem. Okay, so the main headings are autoimmune, infection, and hereditary. Under autoimmune conditions, you have pemphigus vulgaris, mucous membrane pemphigoid, bullous pemphigoid, and epidermolysis bullosa acquisita. And under hereditary conditions, you have epidermolysis bullosa simplex, junction epidermolysis bullosa, epidermolysis bullosa dystrophica dominant and recessive. Even you have Haley-Haley disease. Under infections, you have herpes simplex, varicella zoster, and bullous impetigo. So these are the infections which can produce vesiculobullous lesions. So this is one way we can classify vesiculobullous lesion. The other way in which you can classify is based on the split in the epithelium. If it is the split is occurring above the basal layer at the desmosomal junction, we will call it as a suprabasilar split, under which you have pemphigus vulgaris and paraneoplastic pemphigus. And if the split is occurring at the beneath the basal layer of cells at the hemidesmosomal junction, we have under that we have mucous membrane pemphigoid and bullous pemphigoid, and epidermolysis bullosa acquisita. So these are the two ways in which you can classify vesiculobullous lesion. So when it comes to the question also, you should be able to, when you're coming to the question, like when you're discussing the classification, this is how you have to classify. The two classifications you have to write. In the end, I will again summarize it again and show you how you have to write the answer. So let's talk about pemphigus a little bit. So it means, pemphix in Greek means bubble or a blister. So these are the different variants of pemphigus, but don't worry about all these variants. Most of these are things that you see in the skin, but in the oral cavity, you usually see only two types, like, the ones that we are more interested is pemphigus vulgaris, and we will talk a little bit about paraneoplastic pemphigus. So we are going to focus more on these two aspects. So when we talk about pemphigus, you have to always give introduction to the pemphigus. So how we are going to introduce the pemphigus to the examiner, like in your answer sheet. So you have to first mention that it is an autoimmune mucocutaneous disease, which is characterized by blistering of the skin and the mucosal surface. So mucosal surface means all those like inside the oral cavity and all those areas which are which is actually moist and wet, and the skin is the dry part. And the basic pathology is there is a damage of the desmosomes, and because of the autoantibodies are directed against it. And what are the autoantibodies directed against? It is directed against desmoglein 1 and 3. Remember, it was a transmembrane adhesion protein that we had seen in the previous slide. Now you understood why we went through the desmosomes. Okay, so if you're talking about etiopathogenesis, rather than writing a big etiopathogenesis, like scribbling it down, it is better you can put it into a flow chart or something like that. It becomes much more easier for the examiner to go through it. Okay, so I'm going to put it in a diagrammatic way here. So we have antigen presenting cells, which is presenting self antigens through their MHCs, major histocompatibility proteins. It is taken up and it is being presented to an autoreactive T lymphocyte. The autoreactive T lymphocyte is going to induce the B cells for antibody production, and autoantibody is being produced. It attacks the desmosomes and it produces vesicle formation in the patient. This is how the pathogenesis of a pemphigus is going to happen. So basically, the autoantibodies are attacking the desmosomal protein, that is the desmoglein 1 and 3. So here you can see it diagrammatically. We have the desmosomal complex here, the transmembrane protein. Autoantibodies are coming, breaking them down, and the separation is happening. So this is basically the pathogenesis. So from here, you don't even have to learn the clinical features. You can very well understand that you're going to have a blister or you're going to have a vesicle that is occurring within the epithelium. So what will happen if there is a, the cell-to-cell junctions are broken in within the epithelium, you're going to have a bullae or a vesicle. What about the roof of the bullae or vesicle? It is going to be very thin because it is within the epithelium. Only a small few 2-3 layers of cells are only going to be there on the roof of this blister. So easily it will break it, especially in the oral cavity when you are moving the jaws, it is rubbing against the teeth. So it is very rare that you're going to see intact vesicles or bullae in the oral cavity, especially in the case of a pemphigus. And you're going to see so when you're, as a doctor, when you're going to examine the patient, you're going to see eroded areas or ulcerated areas in the oral cavity. So all of you understood, this is all the clinical features. It's so easy for you to remember the clinical features if you remember the etiopathogenesis. Okay. So another important part of the etiopathogenesis is, this is something that you have to really understand. The skin expresses both desmoglein 1 and 3, while oral mucosa expresses desmoglein 3. So the pemphigus vulgaris, you have autoantibodies directed against both desmoglein 1 and 3. While in the case of pemphigus foliaceus, the autoantibodies are directed against only desmoglein 1. So you will not get lesions of pemphigus foliaceus in the oral cavity, because oral cavity epithelial cells have got only desmoglein 3. So you have only skin lesions. So that is the reason why we are concentrating only on pemphigus vulgaris and we are not going into pemphigus foliaceus. Okay, so that's all about it. Now there are certain factors that can trigger this autoimmune reaction. So it can be, sometimes it is, most of the cases is unknown. Sometimes there are certain dietary factors like garlic, certain drugs like drugs with sulfitryl groups like penicillamine, captopril, or rifampicin, or certain viral infections can trigger this pemphigus autoimmune reaction. So when we talk about the clinical features, so now we have finished the clinical, like, the etiopathogenesis, and we already have an idea about how the clinical features are going to come. So whenever you start with the clinical features, always start with the demographics. Demographics means what is the age, what is the sex predilection, what is the site that is commonly involved. These are all common, like these are all the common headings that with which you have to start your clinical features. So the average age of occurrence for this particular disease is around 50 years. And there is no particular sex predilection in the case of pemphigus vulgaris. The common sites which are involved are gingiva, buccal mucosa, and palate. And certain racial groups like Jews of the Mediterranean origin are more prone for this particular kind of disease. One of the reasons is they marry within their community, and so that particular genetic pool is not very diverse, and they have a particular kind of HLA genes which produces MHC proteins which target the self-antigens more frequently. That's one of the reasons why they have a high incidence of pemphigus vulgaris within the group. So if you write those kind of small points and all, the evaluator will become more impressed about you, and it will help you in scoring more marks for it. Now, when you look at the clinical features, you will see the vesicles will rupture early and you will leaving ulcerations. So you will get these kind of ulcers, as you can see in the picture, with the racked borders, and 50% of the cases you will see oral lesions before the skin lesions. And sometimes for a period of around 1 year, you will see only the oral lesions and not with the skin lesions. And sometimes you have certain pemphigus where only oral lesions will be there. So that is where the importance of the dental surgeon comes to. And the healing of these lesions will not produce any scarring. And this is in stark contrast with the previous, the next lesion that we are going to learn, that is a mucous membrane pemphigoid. And the patients will have something known as a positive Nikolsky sign. That is, when you apply lateral pressure in the areas which is unaffected, those areas will also produce bullae formation. This is called positive Nikolsky sign. This is an important point that you have to underline in your answer sheet. So here you can see the ulcerations that is there on the gingiva. Now, when it comes to histopathology, it's pretty easy. Okay, as I already told you, it is about the desmosomal complexes, not the hemidesmosomes. So you're going to have a split above the basal layer of cells. Okay, so you're going to have a suprabasilar split of the epithelium, and the basal cells which resembles like a tombstones, like the red arrow is pointing to those basal cells which are attached on the basement membrane. They appear like a tombstones on the surface of the connective tissue papillae. Okay, and you will see that sometimes because of the cell-to-cell junctions are broken, you will get intraepidermal blisters with acantholytic cells. Acantholytic means spinous layer cells are like the cell junctions are broken. So here you can see the acantholytic cells like in the picture here. And these acantholytic cells can be demonstrated by a procedure known as Sang smear. So here you can see the red arrow is pointing to these acantholytic cells, which is as a intraepidermal blister. Now, the Sang smear can be asked as a 3 marks question. So you have to have some kind of an idea about Sang smear, and you should note down these points that is going to help you in writing this short brief note. That is a 3 marks question. So what is Sang smear? It is a cytological smear from an intraepidermal or an intraepithelial vesicle. So usually we will use this not only for pemphigus, we can use the Sang smear for herpes vesicles, pemphigus vulgaris, and even for hereditary diseases like Hailey-Hailey disease. So what is the procedure? If an intact bullae is present, you can deroof the bullae, or if crust is present, remove the crust of the vesicle, then scrape the floor of the lesion with a spatula, transfer the material onto a slide, then fix the slide and stain it with pap smear or Giemsa stain. And when you're looking at it, you will see, especially in pemphigus, you will see degenerative changes like swelling of the nuclei and hyperchromatism. So all those things you will be able to visualize in your cytology. This is called a Sang smear. They ask you a question, a 3 marks question for Sang smear, like you can write this much. This is more than enough for you to score good marks in your 3 marks question. So that's about so on the way, we will talk about the 3 marks questions. So again, the Nikolsky sign is a question that can be where you can be asked as a 3 marks question. Again, for when it comes to immunofluorescence, like, the direct and indirect immunofluorescence you can do, and you will see that there is a deposits of immunoglobulin, IgG deposits and C3 deposits on the base, the desmosomal junctions. As you can see in the first picture, the second picture, the areas, the borders of these epithelial cells are all having this fluorescence that has been emitted out. The other diagnostic test that you can use is ELISA for the detection of desmoglein 1 and 3 in the serum. So when it comes to treatment, again, it's an autoimmune reaction. So you're going to have to suppress your immunity. So what you're going to do is, one of the commonest thing that is being used is topical and systemic steroids. And other immunosuppressive drugs are also present, like azathioprine, which can be used for suppressing the immunity and bringing remission for the patient. So when it comes to prognosis, like, it has been found that around 30% of these cases will resolve in a period of 10 years. So it is not a simple thing to be done. And before steroid therapy, like, around 60 to 90% of the patients used to die because of infections and electrolyte imbalances. Okay. And the current mortality rate, even now we have a mortality rate is around 6 to 10%, but it is mainly because of the complications of steroid treatment. And another associated disease that is commonly seen with pemphigus is myasthenia gravis and thymoma. Other autoimmune disorders can be seen in association with pemphigus vulgaris. So this is what you have to write in the case of pemphigus. But when we talk about pemphigus, the another question that can usually come is the paraneoplastic pemphigus. This actually can be asked as a 5 marks question. That's a short note. So this is actually a disease, which is again a vesiculobullous disease, affecting, like, it is seen in people who having a malignancy with them or a neoplasm with them. Usually the neoplasms, like, in which you get paraneoplastic pemphigus is chronic lymphoblastic leukemia or lymphoma. So what is the pathogenesis behind it? Why these people having certain kind of tumors or malignancies are prone to develop pemphigus? So these kind of pemphigus which is developing in the people having tumors are known as paraneoplastic pemphigus. What happens is the tumor cells, they are already mutated and they're producing abnormal proteins. And some of these proteins can, like, look very similar to, molecularly will be very similar to that of a desmosomal molecules. And the body will recognize it as a foreign antigen, and antibodies will be produced against it. And these antibodies which has been produced can cross-react with your normal desmosomal proteins in your epithelium and produce blistering of the mucosa and skin. And that is the reason why this cross-reaction of this antibodies produced against the tumor antigens or tumor proteins is the reason why you get blisters and vesicles in your paraneoplastic pemphigus. So again, autoantibodies are directed here both against the desmosomal proteins and the basement membrane proteins. So here you can see a small, the sign. Usually the signs and symptoms will occur very fast in the case of a paraneoplastic pemphigus. And multiple vesicles can be seen on the skin and mucosa. Here you can see a small vesicle on the skin. And another characteristic feature is the presence of palmar plantar bullae on the, the palmar surface of yours, the hands and the feet, you will be able to plantar surface of the feet, you'll be able to see bullae formation. And the skin lesions will be more papular and pruritic, it will be itching more than the case of a conventional pemphigus. And multiple ulcerations on the oral cavity. And another important feature is the hemorrhagic crusting that occurs on the lips of these patients. 70% of these patients can have conjunctival involvement with scarring, and vaginal mucosa and respiratory tract mucosa can also be affected in these patients. So here, since the basement membrane proteins and the desmosomal proteins both are involved, you're going to see both a subepithelial clefting or subbasilar clefting, as you can see here, and cell-to-cell junctions are also broken down. And sometimes you get abnormal keratinization, like individual cell keratinization at all levels in the case of paraneoplastic pemphigus. And another 5 marks question that you have to be aware is mucous membrane pemphigoid. The other one is mucous membrane pemphigoid. It can be asked as a 5 marks question. Very rarely it has been asked as an essay question. But if an essay question is asked, then also you should be prepared. Just have to put the classification, just like what we have seen in pemphigus. Then you can go with the rest of the things. So here again, when we're starting with a 5 marks question, you should start with an introduction. You can say that it is a immune-mediated subepithelial disorder because it is targeting, the autoantibodies are targeting the hemidesmosomes in the basement membrane attachment. It mainly affects the mucosas. It will not affect the skin much, but you will see that the moist areas, like that is the oral cavity, ocular mucosa, and the genital areas. These are the three areas which is commonly affected by mucous membrane pemphigoid. And it is a very serious condition. It's a serious condition because the ocular involvement can lead to blindness. So as a dental surgeon, like, if you see oral lesions, definitely you have to send the patient for an ophthalmologic consultation. Okay. And it has got a very close resemblance to another vesicular bullous lesion, that is a bullous pemphigoid. But in the case of bullous pemphigoid, the way you have to differentiate is the bullous pemphigoid, you get more skin lesions, while in mucous membrane pemphigoid, you get more oral cavity and ocular lesions or eye lesions. The average age of occurrence is around 50 to 60 years, and the female to male predilection, like more female predilection is there, around 2:1, female to male predilection is there. So again, the etiopathogenesis. If in the pemphigus, it was the desmosomal proteins, in pemphigoid, you're going to see autoantibodies targeted against the hemidesmosomal proteins, that is the BP180, the transmembrane protein in the hemidesmosomes. And usually the immune deposits, the autoimmune antibodies will be deposited in the areas of the lamina lucida and the lamina densa interface. And when a blister is occurring, you will see the basement membrane with the autoantibodies will be there on the roof of the blister. So we can put again a diagrammatic representation for it. So antigen presenting cells with self antigens, they have an MHC protein. They present the self antigens, the hemidesmosomal protein, that the BP180 is being presented by the antigen presenting cell. It is it activates the autoreactive T lymphocyte. It induces the B lymphocyte to produce autoantibodies, again attacking the hemidesmosomes and vesicle formation. But here, when you look into this particular pathogenesis, like, you will see that the vesicle formation is occurring at the basement membrane region. So if a vesicle is occurring, what will happen? The roof of the vesicle or the blister will be more thicker because the whole lining of the epithelium is there. It's not like how it was in pemphigus. Pemphigus, it was within the epithelium. But here, it is beneath the epithelium, beneath the basal layer. So you have the whole layer of thickness of epithelium forming the roof of the blister. So there is a possibility that when you're clinically observing the patient, you may be able to see intact blisters in the oral cavity, or intact bullae can be seen in the oral cavity. So it's an important clinical sign, but it's going to help you in differentiating whether it is a pemphigus or a pemphigoid. But it's not foolproof. You have to go for a histopathology. Another important feature that you have to remember here is the autoreactive T lymphocytes. They will be producing pro-fibrotic cytokines, or like they will be producing certain proteins which induces fibrosis. So usually when these vesicles heal, they will heal by scarring. That is one of the reasons why when you have ocular pemphigoid, or you have eye involvement in pemphigoid, the healing occurs by there will be scarring of the conjunctiva of the bulbar conjunctiva of the eyeball, resulting in the blindness. That is the reason why when we have to be very careful about this particular kind of disease. If you see these kind of lesions in the oral cavity, and if you're confirmed your diagnosis with histopathology as a pemphigoid, definitely you have to send the patient for a ophthalmologic consultation. So this is the hemidesmosomal complex we have learned, and you can see the transmembrane protein is BP180. And this BP180 is targeted by the autoantibodies in mucous membrane pemphigoid. And once it has been destroyed, you're going to see a separation of the epithelium from that of the underlying basement membrane. So when you look at the clinic, so that with that, the etiopathogenesis is over. If we go to the histopathology, when you go to the clinical features, you will see that it mainly affects the oral and the ocular mucosa. So site involvement, and it closely resembles to that of the bullous pemphigoid. Again, the demographics, average age around 50 to 60 years, gender predilection 2:1, like more prevalent in females. The common site involvement is gingiva, and rest of the oral mucosa can also, palate and all can occur, but commonly we see it on the gingiva. So with this, we can start with the clinical features. Then you go to the oral lesions are seen in most of these patients, and you can see intact vesicles or bullae can be seen. You can see one intact vesicle here, in the oral cavity, unlike pemphigus vulgaris, where like you don't see any intact bullae or vesicle. You can see some intact bullae or vesicles in the case of a pemphigoid or a mucous membrane pemphigoid. And the vesicles will rupture and the area will appear ulcerated and denuded, and this will persist for months and the patient will be in real pain. And when these lesions heal, they will heal with scarring. Okay, the fibrosis will occur in these areas. So the other sites of involvement are conjunctiva, nasal mucosa, esophageal, laryngeal, vaginal mucosas, and sometimes even a little bit of skin involvement can also be there, because biology is always a science of exceptions. Okay. Now this is one picture like which I have taken from Neville, where like you can see there was an ocular pemphigoid or like eye involvement, and after that like it has undergone healing, and you can see the bulb. There is adhesion between the bulbar and the palpebral conjunctiva, and this is known as symbelliferons. This is known as symbelliferons. Okay, if you can add small notes on the ocular involvement in your answer sheets, I don't think anybody else will write it, but now everybody, like I think like 150 people are there in this, and some people are there in the YouTube channel. So you guys can write it, and you're going to have an extra edge like when it comes to your scoring the marks. And later, the scarring will occur, like, you know, and it will close off the lacrimal glands, and there will be called like, you know, ulcerations on the cornea, producing keratin formation, resulting in blindness. So this is a patient who had ultimately has gone for blindness, who had ocular pemphigoid. So histopathology, again, you can see a subepithelial split and with mild chronic inflammatory cells. Immunofluorescence, you'll be able to see linear deposits of immunoglobulins and C3 in the basement membrane zone, as you can see here. So that's again the treatment when it comes, again, immunosuppression with steroids and other immunosuppressive drugs. Again, the most important thing is ophthalmology consultations. So that's all about the main things in the vesiculobullous lesions. So here, I'm going to tell you like how you have to frame your answers here, how you have to write your answers here. So if a question is being asked about classify vesiculobullous lesions and discuss in detail pemphigus vulgaris, how you're going to write the answer. Now, before you write any essay question, you have to make sure like you have to write the contents first. Okay, you have to put the headings under which you are going to write the answer. So if I'm going to write an answer for this particular question that we have discussed in the beginning, I'm going to write contents like this. So the contents as first is classification, because each of these contents are going to get score marks, and the evaluator is not going to spend too much time on your paper. So it is your responsibility as a student that you have to bring your like capture the attention of your evaluator so that you'll be able to score maximum marks, and you have to highlight those areas which the examiner, like which the evaluator is going to think is important, and so that you'll be able to score more marks in these areas. So you have classification, you have to have an introduction, etiopathogenesis, the triggering factors, the clinical features, histopathological features, immunofluorescence findings, and treatment procedure, treatment and prognosis. So when it comes to the classification, we have already discussed there are two ways in which you can classify vesiculobullous lesion. The first classification is based on the etiopathogenesis, and the second classification is based on the level of epithelial separation. So we have already discussed it. So you have to write the three headings, you have to underline them, you have to put the examples under each heading. Then comes the levels in which the epithelial separation is happening. You can have suprabasilar split and you can have a subbasilar split. Under suprabasilar split, we have pemphigus. Under subbasilar split, we have mucous membrane pemphigoid. Then you have to start, we can start with pemphigus vulgaris. We can start with an introduction. We can give, like, tell that it is a mucocutaneous disease. It is an autoimmune disorder. The transmembrane, desmosomal transmembrane proteins are being targeted by the autoantibodies. And from there, you can go to your etiopathogenesis. So rather than writing a long essay about like, or a lot of scribbling down a lot of things about etiopathogenesis, if you can put that into a flow chart, the evaluator, it'd be very easy for them to understand that you know about the etiopathogenesis. So if you can put boxes like this, and if you can put a flow chart like this, you will be, you can score more marks, like, you know, when it comes to your examination. And you have to underline autoantibodies directed against desmoglein 1 and 3 So that part you have to underline. So you have to underline with red pen. Okay, that's very, very important. Unless you underline, you're not going to the headings and the subheadings you have to underline, and the important points you have to underline. Unless you do that, you are not going to draw the attention of your evaluator. Now, the triggering factors you can mention. Then you can mention about the clinical features. The two important things that you have to mention. So you can start with the age, you can start with the sex predilection, you can start with the site predilection, you can talk about what kind of lesions you're going to see in the oral cavity. Then you have to mention that the healing will not produce scarring, because that is one way you are going to differentiate pemphigus vulgaris with that of mucous membrane pemphigoid. Then you have to mention about positive Nikolsky sign. So when lateral pressure is applied on to unaffected areas, bulla formation will occur. So this positive Nikolsky sign can be asked alone as a 3 marks question. So then you define what is the positive Nikolsky sign, and you give examples of diseases having positive Nikolsky sign for a 3 marks question. Okay. Then comes to the histopathology. Very easy. The histopathology is very easy. You can say acantholysis, suprabasilar split. So that part you have to underline. That's very important. Acantholysis, suprabasilar split. And the basal cells are arranged as a row of tombstones. So these kind of words like tombstones, what you call lessic anchorings, those kind of things always ring in the head of an exam evaluator, and they will be expecting those terminologies to be present in your answer sheet. So if you underline them, immediately they will notice that and you will get the marks. And another important thing is acantholytic cells and SANG test. Okay, so these are the important things, and you have to draw the histopathology H&E diagram at this particular place, not after everything is over in the end, you can't draw the diagram. Along with the histopathology, you have to, where you're writing about histopathology, you have to write about you have to draw the diagram of the pemphigus. And don't spend too much time in drawing the diagram. You just need to have a decent diagram and mark the parts. For that, you need to practice and practice so that you can draw the diagram at a fast, you can draw the diagram fast. And you should not spend more than 1 minute for drawing the diagram. Okay, within 1 minute, you should be able to finish the diagram. So fast you have to draw, and it should be pretty decent also. And you should not, and when you're marking also, you should not mark it properly. And you can mention about immunofluorescence, like a small heading, and about the differential diagnosis. So you can mention about the other vesiculobullous lesions under your differential diagnosis, and a small note on the treatment aspect. So this is how you have to frame your answer sheet. And like around 1.5 to 2 pages, we get filled by the time you write, expand on all these headings. So this way you will be able to score maximum marks for this particular essay question. And you have to also mention a small note on the prognosis also for it. So the next question that is being commonly asked is the skin diseases. Okay, on the skin diseases is classify skin diseases and discuss the etiology, the clinical features, and the histopathology of lichen planus. So that is the next question that is being commonly asked in as an essay question. So these are the 2 questions that we're going to focus today. So again, when you talk about the classification, and you have to classify all the mucocutaneous or the skin diseases, you can classify them under 3 headings. Okay, that is autoimmune, you can under infections, and hereditary. The same way we had classified the vesiculobullous lesions in the beginning. Based on the etiopathogenesis, the mucocutaneous or the skin diseases can also be classified under these 3 headings. So you're going to have pemphigus vulgaris, mucous membrane pemphigoid, lichen planus, and erythema multiforme. So here, unlike the previous classification, we are adding lichen planus and erythema multiforme also into here. So this can be considered as allergic or autoimmune disorders. Under hereditary, you have epidermolysis bullosa simplex, junctional epidermolysis bullosa, epidermolysis bullosa dystrophica dominant, recessive, and another hereditary disease, that is the Haley disease. Infections also can show present as skin disorders like herpes simplex virus infections, varicella zoster, bullous impetigo, and all. So this is how you can classify the skin disorders in this particular when this question is being asked. Now, when it comes to lichen planus, it's another important question. So when it comes to lichen planus, it is basically a mucocutaneous disease, affect the skin or the mucosa or both. Okay. So oral mucosal involvement is frequent and often precedes the others. So commonly you're going to see oral mucosal involvement, and basically it is an autoimmune disorder. So there is some kind of autoimmune mechanism that is functioning, and where in which the like in the basal keratinocyte. So what happens here is the CD8 positive T lymphocytes, which is actually the killer T lymphocytes, which goes and induces that apoptosis of the basal keratinocytes. So they induces the apoptosis or death of the basal keratinocytes. So you know that the epithelium has got stratum basal, spinosum, spinosum, and granulosum and corneum. So the basal layer of cells are being targeted by the killer T lymphocytes, and they can induce the apoptosis of the basal keratinocytes. So that is a basic pathology of lichen planus. So remember, whenever we are talking about any essay question or any things like that, you can always mention, like in the introductory part, what kind of disease it is, like, what is it's a mucocutaneous disease, or it's a cyst or a tumor or something like that you can mention. Then you can talk about what is the basic pathology behind it and the pathogenesis mechanism very briefly. With this, you can finish off the introduction. So very easily you can frame an introduction for any of these kind of questions. So when we talk about the etiopathogenesis, like if you start looking at the articles and all those things, it's very complicated. So basically only two things are happening. The CD8 positive killer T lymphocytes are targeting the basal keratinocytes and inducing apoptosis of the basal keratinocytes. So that's the basic pathology that occurs in the case of a lichen planus. So what happens is the self antigens of the keratinocyte, especially the basal keratinocytes, in certain people, because of certain triggering factors, or like maybe we really don't know like what are the reasons in many cases. Sometimes stress is a inducing factor. That's an important thing that you have to is stress. Most of these lichen planus cases are stress induced. So that you have to write in your introductory part. Okay. So in these people like which is stress induced, like the self antigen of the keratinocyte will be usually presented by the antigen presenting cells. Like, the self antigens will be presented by the antigen presenting cell in the epithelium. So what is that antigen presenting cell? It is a Langerhans cells. So they have the major histocompatibility protein MHC2 on it. And these self antigens from the basal keratinocytes are presented onto the CD8 positive killer T lymphocytes. And these killer T lymphocytes can induce apoptosis. Now, not only that, the keratinocyte itself through MHC1 can present the self antigen to the CD4 positive helper T lymphocyte, and these CD4 positive helper T lymphocytes can in turn activate the CD8 positive killer T lymphocyte. So there are two ways in which the CD8 positive killer T lymphocytes are activated in the case of a lichen planus. So this CD8 positive killer T lymphocyte can induce apoptosis of the basal keratinocyte. And this is the basic pathology in the case of a lichen planus. So when we talk about the clinical features of lichen planus, so I hope now you are all clear about the basic pathogenesis of lichen planus. In the case of lichen planus, it is basically induced by the killer T lymphocytes, autoreactive killer T lymphocytes, which induces apoptosis of the basal keratinocytes. Okay, so the basal layer of epithelium is lost in the case of a lichen planus. So the male to female ratio, the sex predilection. So when we're talking about the clinical features, you can always start with the sex predilection, and you can start with the age predilection and the basic clinical features of how it has been distributed. And it is basically one of the major triggering factors for lichen planus is stress. So the male to male ratio is around 1.4 to 1. That is, more female predilection is there in the case of lichen planus. This is something that is very common with most of the autoimmune disorders. And it is predominantly seen in adults over the age of 40 years. Just like pemphigus and pemphigoid, remember, for them also, the average age of occurrence of the diseases were around older age group, around the age of 50. Okay. And it's usually distributed in a bilaterally symmetrical pattern. Like both areas, all the bilateral areas will be seen with the lesions. If it is in the skin also, like bilaterally, you'll be able to see. And in the oral cavity also, right buccal mucosa is there. You can see it in the left buccal mucosa also, or multiple sites will be involved because it is not a localized lesion, but it is a systemic lesion. Okay. And in the case of skin, you can see hypertrophic scars formation and severe pruritus or itching will be there. In some areas where stress is being applied or like where mechanical trauma is there, in those areas will have more chances for the lesions to develop. Okay, that particular phenomena is known as Koebner's phenomena. That is known as Koebner's phenomena. So when we talk about lichen planus, it is nice to even like mention a little bit about the skin manifestations of the lichen planus. So you can have skin lesions like, which are small angular flat top papules or small elevations, a few millimeters in diameter. You can see it on the skin here. Small papular elevations on the skin of a few millimeters in size. Okay. And the usual sites for occurrence is the flexor surfaces of the wrist and the forearm and the inner aspect of the thighs and the trunk. These are the common sites where you're going to have the skin manifestations or the skin lesions of lichen planus. Okay. Now, what will happen is later, these lesions can gradually grow and coalesce or like fuse with one another to form plaques, okay, which are covered by a fine glistening scale. Like, you can see plaques like this on the skin, which is covered by glistening, like, keratotic, highly keratotic scales will be there on the surface. Okay. And the lesions, as they progress, as the time evolves out, like, you can see the skin lesions will progress. Early lesions will appear red, but as the inflammation is continuing, more and more of keratinization will happen on the surface of the skins, and you will see more purplish or violaceous hue will be there, or more like, darker hue will be there, and more pigmentation will have occur and on these lesions, and you will see a dirty brownish color will be developing on these skin lesions. And later, as the time goes on, it becomes a more hypertrophic scar formation. You will see hypertrophic scar formation, especially on the shin areas, and there will be severe pruritus for these patients having lichen planus. Pruritus means itching on these lesional areas. Now, if you observe like many of these skin lesions, you will be able to visualize grayish white lines on it. That is known as the Beckham's striae. You can see these grayish white lines on the lesion. Okay, these are known as the Beckham's striae. So this Beckham's striae is an important point that you have to remember when it comes to a lichen planus assay. You have to underline that. So the clinical features, so the skin features are over. Then we will go into the oral mucosal features. Okay, so usually in the oral mucosa also, you're going to see bilateral distribution of these lesions, and the patients will have severe burning sensation on taking spicy food. Not all the time. There are certain lichen planus cases which can be asymptomatic, which may not produce any, only clinical appearance of the lesion will be there, but the patient may not be symptomatic. In those cases, you don't have to worry too much. But most of these patients will have burning sensation on taking especially spicy foods. And the site of involvement is commonly seen with the buccal mucosa, followed by tongue, lips, and gingiva, and the other sites. So these are the things that you can mention in your clinical features when it comes to the oral mucosa. So you have to divide your clinical features between the skin lesions and the oral mucosal lesions. Now, you have to mention about the clinical types of oral lichen planus. So there are around 5 types of oral lichen planus, which includes reticular lichen planus, atrophic lichen planus, erosive lichen planus, hypertrophic lichen planus, and bullous lichen planus. So around 5 types of lichen planus clinical types have to be mentioned in the oral lichen planus heading. So in the reticular lichen planus, you're going to see it's the most common type of lichen planus that you're going to see. You're going to see interlacing white lines. You can see these interlacing white lines in the buccal mucosa. This is known as Beckham's striae. You can see that in the skin also, in the oral cavity, in reticular type of lichen planus, it is very prominent. In the other types of lichen planus, or subtypes of oral clinical variants of lichen planus also, you will be able to see Beckham's striae. Okay, and the white lesions can also appear as small papules, papillary kind of lichen planus can also be there. Papillary projections can also be seen. And many of these lesions will wax and wane for weeks. Like sometimes it will be more active, burning sensation will be there. Later it will calm down, it will come down, the what you call clinical symptoms will come down and become asymptomatic. So the waxing and waning of these lesions will keep happening for the patient. Many of these lesions of reticular lichen planus can be asymptomatic also. The next one is atrophic type of lichen planus. You will see that atrophic means the thickness of the epithelium has come down. Okay, and the epithelium has become thin. So the clinical feature, what you're going to see here is you're going to see smooth erythematous and poorly defined lesions. And it's usually associated with reticular pattern. You can see that Wickham striae in the borders of these lesions. It's very important because unless you see Wickham striae, it's not very easy to differentiate it from the other mucocutaneous disorders like the vesiculobullous lesions, like pemphigus and all, because there also you're going to see red and erythematous lesions on the oral cavity. So identifying this striae pattern in the lesions are very important in the case of atrophic lichen planus for making the clinical diagnosis. Next comes the erosive type of lichen planus. Now this is very, very important. Another essay question that comes in your epithelial pathology is what are defined pre-malignant lesions and conditions, like or potentially malignant disorders and things like that. So when they come, like there is this lichen planus is also again categorized under a potentially malignant disorder or a potentially malignant disorder or a pre-malignant condition. The reason for that is erosive type of lichen planus, because this erosive type of lichen planus has got a chance of undergoing malignant transformation. The malignant transformation rate for an erosive lichen planus is around 0.3 to 3%. So that is why it is put under the heading of also under potentially malignant disorders. This type of lichen planus is symptomatic. The patient having erosive lichen planus will be symptomatic. The patients will have atrophic erythematous areas with central ulceration. So here you can see areas of central ulceration. Okay. And the periphery of the ulcers will show striae, white radiating striae can be seen. Another lesion that looks exactly like this is discoid lupus erythematosus. Okay, the differential diagnosis for an erosive lichen planus is a lupus erythematosus. But remember, lupus erythematosus, discoid lupus erythematosus will not occur exclusively on the oral cavity. It will have that characteristic malar kind of the pattern of lesions on the skin, on the facial skin will be there. Without facial skin or the skin lesions, you will not have oral lesions in the case of discoid lupus erythematosus. So easily you can clinically distinguish between erosive lichen planus and discoid lupus erythematosus. And if still you have doubts, you can always, there are ways in which in histology, you'll be able to differentiate between a lichen planus and a lupus erythematosus. The next type of lichen planus is hypertrophic type of lichen planus, where you can see well circumscribed elevated white lesions, which resembles like that of a leukoplakia. So it's very difficult to distinguish these kind of lichen planus cases from that of a leukoplakia. Now, the lesions, the lichen planus cases, lesions that occur on the dorsum of tongue, will most of the time will appear very similar to that of a leukoplakia. So when the lichen planus lesions occur on the dorsum of tongue, it is usually a hypertrophic type of lichen planus. And the last type of lichen planus is a very rare type, that is a bullous lichen planus. So here you can see a small bullae in the lichen planus. You can see a small bullae that is there, on the lichen planus. And once they rupture, easily it will rupture. Once they rupture, they will, you are going to see erosive areas in the area of the rupture. Okay, so that is about the clinical types of oral lichen planus. So what all things have we seen? We have seen the classification. We had seen the introductory part of the lichen planus. Then we have mentioned about the pathogenesis. We had seen the flow chart of how you have to write about the pathogenesis of lichen planus. Then we have seen the clinical features, especially the skin features, general clinical features. Then we have seen how the clinical skin presentation of lichen planus on skin is there. Then we had seen the clinical types of oral lichen planus. Then we have seen the how each of these lichen planus is going to appear in your clinically, how it is going to appear, what is the characteristic clinical features of each of these type of oral lichen planus. Now we are going into the histology. Now, many people will say that, like, it's very difficult for them to remember the histology of lichen planus, or like histology of anything. Like, it's very complicated. They will talk like that. Now, let me tell you, if you remember the pathogenesis, it's very easy for you to remember the histology. Okay, so what is the main pathogenesis or main pathology that is occurring in the case of lichen planus? You're going to see that the cytotoxic T lymphocytes, they are going to induce apoptosis of the basal keratinocyte. So when you're taking a section on, when you're examining the histology of a lichen planus, you're going to see that the basal layer of cells are absent. There is a degeneration of the basal keratinocyte. So that is the first feature that you have to mention in histopathology. Basal cell degeneration. That's an important thing. Without basal cell degeneration, you cannot call something as a lichen planus. Okay. Now you know how the retiridges are present. There are extensions like the retiridges are extending down. And once the basal keratinocytes are destroyed, they will take a shape which is actually conical. So that is why the basal, the retiridges will appear like a sawtooth. Okay, so because of the basal cell degeneration, you will see that the retiridges are sawtooth retiridges. And what is inducing this basal cell degeneration? It is a cytotoxic T lymphocyte. So you need to see a lot of T lymphocytes or lymphocytic infiltration has to be seen beneath the epithelium for that. Am I right? So beneath the basal layer, you're going to see, like, you're going to see a subepithelial band of lymphocytes. You're going to see a subepithelial band of lymphocytes. And these degenerating basal cells will take up a shape of a eosinophilic homogeneous round material, will have a homogeneous round material appearance. And that is known as civet bodies. They are known as civet bodies. So now we have seen basal cell degeneration. Because of the basal cell degeneration, we have sawtooth retiridges. Then we have degenerating keratinocytes, and which are seen as civet bodies. Then we have a subepithelial band of lymphocytes. Because these lymphocytes has to be there for inducing the basal cell degeneration. Then, since the basal, we know that the epithelium is attached to the underlying basement membrane by means of hemidesmosomes. So once the basal layer is gone, the strength of attachment of the epithelium to the underlying connective tissue is weakened. So when we are taking sections or when you're taking biopsies, very easily the epithelium will get peeled off or will get separated from the underlying connective tissue. So this separation that you see in your histology between the epithelium and the underlying connective tissue is known as Max-Joseph spaces. That is what you call as a Max-Joseph space. Now, you can see based depending upon what type of lichen planus you are looking. For example, if you are seeing a hypertrophic type of lichen planus, or you are seeing a reticular type of lichen planus where you are seeing white lines or white areas, that is all because of excess amount of keratinization that is occurring. You're going to see excess amount of keratinization, so you can get ortho or parakeratosis, or excess amount of keratinization is known as keratosis. Then you're going to see that there is a variation in the thickness of the spinous layer. Or in the case of hypertrophic type of lichen planus, you may see a thick layer of spinous layer, while in the case of atrophic lichen planus or erosive lichen planus, you're going to see a very thinned out layer of the epithelium. So let's see the histology now. So now all of you are like, let me just go back and like refresh your histopathology once again. You have basal cell degeneration, sawtooth retiridges because of basal cell degeneration. So basal cell degeneration has to be there. Then only it becomes lichen planus. Then because of basal cell degeneration, you have sawtooth retiridges, and the degenerating basal cells will appear as civet bodies. Then what is inducing the basal cell degeneration? It is the subepithelial band of lymphocytes. And because the Because the basal cells have already degenerated, the epithelial mesenchymal junction has become what they call loosened out. So you get separation between the epithelium and mesenchyme, that is a max dose spaces. So these are all the things that you're going to see in your histology. Now let's look into the histology and try to understand the histology a bit. Now, this is a comparison between a lichen planus and a normal epithelium. So don't get scared by looking at the histology. It is pretty easy if you try to understand, like, what is happening at the cellular level. So, like, there are like more interesting things are happening at the microscopic levels than in our lives. Okay. So here you can see the picture that in the normal epithelium here. You can see the basal layer. The red arrow is pointing to the basal layer. And you can see how the basal layer are arranged. So you can see columnar or cuboidal cells on the basal layer. And try to see the same thing in your lichen planus. You cannot see a basal layer in the case of a lichen planus. Okay, so that is the key for making the diagnosis of a lichen planus. Okay, the second thing is, along with that, what is inducing the basal cell degeneration? It is the presence of lymphocytes. So here you can see a subepithelial band or collection of lymphocytes are present. These are the lymphocytes which induces the degeneration of the basal layer. Now, because of this basal cell degeneration, you can see that this retiridges have become sharpened out, or like they have become conical, and they appear like a sawtooth. So that is why we call it as a sawtooth retiridges. Now, like, this degenerating basal cells will appear as homogeneous eosinophilic globules at the epithelial mesenchymal junction. So the civet bodies can be asked as a 3 marks question. Okay, so you have to remember that civic bodies. So here you can see some of these homogeneous eosinophilic masses at the epithelial mesenchymal junction of a lichen planus. The next one is the weakening at the epithelial mesenchymal junction. And when you are looking at the sections, you will see clefts beneath the epithelium that is known as the max Joseph spaces. You can see here, these are the max Joseph spaces. Now, if you're looking at the immunofluorescence, you can see the fibrinogen and fibrin deposits in a linear pattern in the basement membrane zone. We can see a linear pattern of deposits of fibrinogen and fibrin at the basement membrane zone. And when you look at the differential diagnosis, what all are the different? So this is about the histopathology. So let me just go back and show you, like, remember, like, refresh once more about the histopathology: basal cell degeneration, sawtooth retiridges, civet bodies, subepithelial inflammatory cell infiltrate, subepithelial band of inflammatory cell infiltrate, max Joseph spaces. If you can write this much, the histopathology is over. Okay. Then when it comes to differential diagnosis, in the case of reticular lichen planus, one of the differential diagnoses that you have to consider is lichenoid mucositis, which is actually an allergic reaction to either an amalgam filling or some kind of a restoration, or because of some kind of drugs that has been taken. So how to differentiate from lichen planus from that of a lichenoid mucositis clinically is with the proper history taking. If you take a proper history, you'll be able to distinguish between the lichen planus and a lichenoid mucositis, which is actually an allergic reaction. The other one is a graft versus host reaction. This is a condition where, especially in the case of patients having leukemia or lymphoma, things like that, where their bone marrow is being replaced. Their bone marrow is completely irradiated or given chemotherapy, and their bone marrow is completely destroyed. And in the place where their bone marrow is there, a donor bone marrow is being put over there. Okay. Now what happens is the recipient is receiving a bone marrow from a donor, and the immune cells are produced from these bone marrow cells. Okay, the lymphocytes or the neutrophils and all are being produced from these bone marrow cells. The bone marrow is actually foreign, so they are going to induce some kind of a skin reaction that is known as a graft. They're going to produce a reaction. They're going to, these new cells that has been immune cells that has been formed from the new bone marrow can actually recognize the recipient's tissue as foreign and can start attacking them. And that is what you call as graft versus host reaction. And you can get lichenoid lesions or in these graft versus host reaction. In the case of erosive lichen planus with Vicam striae and all, you can they will resemble very close to that of lupus erythematosus. So I have already mentioned about that. But in lupus erythematosus, you can very well see skin lesions and characteristic skin lesions, especially in the malar region. When characteristic Vicam striae are absent, you can, the other ulcerative diseases like discomatous gingivitis, which is actually a clinical, it is not a diagnostic term, it is just a descriptive terminology that has been used to describe the gingival lesions that you see in vesiculobullous lesions and all, and another disease known as chronic ulcerative stomatitis. But in these lesions, the histopathology will help you in making the diagnosis. So the treatment for lichen planus is steroids, that is the immune suppression. So you can give topical steroids for lichen planus if they are refractory to, or if they are not resolving with topical steroids and the patient is really symptomatic, you can go for systemic steroids. And one of the problems with topical steroid application in the case of lichen planus is superimposed candidal infection. Okay, because when we are giving steroids, you're going to bring down the localized immunity of the lichen planus, the localized immunity in the oral cavity. And we have opportunistic infections like candida, because already the candidal hyphae or the candidal organisms are there in everybody's oral cavity. It is kept under control because of the body's immune system. But once you start giving the steroids, like oral steroid, like topical steroids, this immunity will come down and you can get superficial candidiasis. So here is a picture of an erosive lichen planus patient who was being given topical steroid application. And you can see now, it is filled with a lot of candidal infection was there, and anti-candidal treatment was done, after which the lesions were completely resolved. So when you're giving a treatment for lichen planus, topical steroids for lichen planus, you have to give topical antifungals also, so in order to avoid this kind of a complication. So usually these patients are followed up for erosive lichen planus for a period of around 3 months, and especially because especially erosive lichen planus, because there is always a possibility for malignant transformation, and a biopsy has to be done so that you'll be able to differentiate between lichen planus, lichenoid mucositis, or if you have to see whether any kind of atypia or cellular atypia or dysplastic features are there, which can lead to malignancy. So that's about lichen planus. So most of the 2 essays which is commonly asked in the skin chapter is over. I hope I'm not bored you guys. Now let us go into how we are going to frame the answer when this question is being asked in your answer sheet. Okay, the presentation is well and good, but you need to know how to frame the answers in your answer sheet. So again, for an essay question, you have to write contents. Okay, so you have to start with classification, because classification is a part of the question. So 2-3 marks will, out of 10 marks, 1 or 2 marks will be going for classification. So you cannot miss the classification. So here, most of the time, this classified skin disease is a very general type of classification. So you can put it under a classification of etiopathogenesis, just like what we have seen. You have to go with an introduction, etiopathogenesis, clinical features. Then under clinical features, you can again divide them under 2 headings, that is skin lesions and oral lesion types, and elaborate on the oral lesions. Then you go into the histopathologic features. Now, I told you histopathology features, very easily you can remember: basal cell degeneration, sawtooth retinoides, civet bodies, subepithelial hyalinization, subepithelial inflammatory cell infiltrate. So it's very easy for you to remember that. Now I think I think histology would have become very easy for you now. Then immunofluorescence studies, the differential diagnosis, and the treatment and prognosis. So this is how you have to write your classification. You start with your classification. You tell what is the premise of the classification, that is etiopathogenesis. What are the headings under which you're going to do the classification? Underline those points. Then you give the examples under each of these classification, each of these headings. Then you talk about the introduction. So introduction can always start with what kind of disease it is. It is a mucocutaneous disease. What are the common sites involved? Oral mucosal involvement with skin involvement. It is an autoimmune disorder. What is the basic pathogenesis? What is the basic pathology that is happening over there? So with these kind of points, you can write a small introduction. Then you have to go to the etiopathogenesis. So instead of writing a big etiopathogenesis, like nobody is going to sit and read your paper, that you let everybody is going to glance through your paper, and the answers or the points has to jump out of it for you to get score marks. So you can write, put a flow chart like this, so that like easily they will know that you know about CD8 positive T lymphocytes, and you know that basal keratinocyte has been undergoing apoptosis. Once they know that, like it's more than enough for an undergraduate level for etiopathogenesis. Very simple thing for you to remember. Next comes the clinical features. Start with your clinical features with your demographics. Okay, so start with your age predilection, start with your sex predilection, then go with the general clinical appearance, that is distributed bilaterally symmetrical pattern. And another important point which I have not mentioned here is most of the lichen planus cases are stress induced. Okay, so that also you have to mention in the clinical features. Now, chronic cases, you can see scars on the shins, severe pruritus, Kopner's phenomenon. So these kind of like catchy words has to be underlined. So these are the things that usually the evaluator will be looking into. Then you talk about the skin lesions. The skin lesions, like already we have mentioned, like, usually develops an angular flat top papules a few millimeters in diameter. Once you have seen the pictures, like it becomes much more easier for you to remember these clinical features. Like it's just a small elevation, flat top elevations, and usually seen in the flexor surfaces. Slowly it will progress and white scales will be formed on the surface of it. You'll be able to see white striae on it. Okay, that is a Wickham striae. Wickham striae has to be underlined. Okay, very important. Okay, they will expect you to know about Wickham striae. Then comes the oral lesions. Give a small introduction about oral lesion. Just like in the skin lesion also, the oral lesion also you will see a bilateral distribution. Produces burning sensation on taking spicy foods. And what is the site predilection? Mostly seen in buccal mucosa. The other site of involvement are tongue, lips, gingiva. Then you talk about what are the clinical types. You have to mention 1, 2, 3 like this, and you have to write it. Clinical types of oral lichen planus, under which you're going to talk about reticular lichen planus, atrophic lichen planus, erosive lichen planus, hypertrophic lichen planus, and bullous lichen planus. And each lichen planus, oral lichen planus type, you take separately and you describe a little bit about each type of lichen planus. Okay, as I have mentioned earlier. So you talk about reticular lichen planus, then you talk about atrophic lichen planus, then you talk about erosive lichen planus. So when you talk about reticular lichen planus, remember to underline Wickham striae. Very, very important. Okay. The next one is erosive lichen planus, because it is the symptomatic type, mostly the symptomatic type of lichen planus, and you're having a central ulceration that you have to mark. But you need to look for the presence of radiating striae on the periphery of these ulcerations. And the most important thing is it has got a pre-malignant potential. It is a potentially malignant disorder. The malignant transformation rate is around 0.3 to 3%. So that you have to underline again. Hypertrophic lichen planus, again, you can underline that it resembles like that of a leukoplakia, and oral mucosa shows vesicle formation. Like in the case of bullous lichen planus, you can say that it shows basic bullae formation, and which can rupture and form into erosive areas. So when it comes to histopathology, again, you have to underline certain important points. Remember, you will not call something as a lichen planus without basal cell degeneration and a subepithelial band of lymphocytes. So that part you have to underline. Then everybody will be looking for a sawtooth retrovirus. People like this kind of catchy phrases, like, will stay in the, like, heads of people, like, so you have to underline those points. So you have to underline sawtooth retrovirus, civet bodies, hyaline bodies, or cytoid bodies. That's the name for the same thing. Okay, so don't have to worry about it. But remember, they can ask the civet bodies or hyaline bodies or cytoid bodies as a 3-mark question. So remember all these 3 names. So it can be asked as a 3-mark question. Then write about the pathogenesis of lichen planus. Okay, about that basal cell keratinocytes are being induced to undergo apoptosis by the basal, the cytotoxic T lymphocytes, and this degenerating basal keratinocytes are known as, like, will appear as like round eosinophilic bodies at the epithelial mesenchymal junction, and these are known as civet bodies. This much if you can write, like, that will be enough for a 3-mark question. With the 5 minutes, this much only anybody can write. Okay. And the weakening of the epithelial mesenchymal junction, that is the Max-Joseph spaces. So Max-Joseph spaces also has to be underlined. So remember, these important keywords has to be underlined. Okay, that's the way you have to score. And then you have to draw a diagram, a neatly labeled diagram with showing basal cell degeneration. Just don't have to draw basal cell. So that is basal cell degeneration. Okay, then you can put a lot of inflammatory infiltrate, subepithelial band of inflammatory infiltrate. So this diagram, you have to draw a decent diagram. You have to draw within 1 minute time. So if you expect to draw the diagram first time at the time when you are there in the exam hall, that is never going to happen. So you have to draw at least 5 to 10 times, and you have to make it the speed for drawing the diagram so that you will not lose marks, lose the time in drawing the diagram. Okay. Then you can mention about a small note on the immunofluorescent pattern, that is deposition of fibrinogen and fibrin in a linear pattern at the basement membrane zone. Then the differential diagnosis. Verticular type of lichen planus has to be differentiated from lichenoid mucositis and graft versus host reaction. Erosive type of lichen planus has to be differentiated from lupus erythematosus. In erosive type, if the striae are not seen much, you have to consider the differential diagnosis of other ulcerative diseases like discombinate gingivitis and chronic ulcerative stomatitis. Treatment, topical steroids, complications of superimposed candle infection is there. Follow-up of the patient for erosive lichen planus for at least for the period of 3 months. And prognosis, you have to ask, we have mentioned in the case of erosive lichen planus, the pre-malignant potential is around 0.3 to 3%. So that we have to mention as in the prognosis. So thank you so much for your patient listening. And other questions that can be frequently asked is erythema multiforme. So they can be asked as a 5 marks question or even asked as a 3 marks question. So if somebody asks you about erythema multiforme, you can mention about that it is induced. There are 3 types of erythema multiforme. Erythema multiforme minor, where only oral mucosal lesions are there, and mucosal lesions are there. And when it comes to erythema multiforme major, skin lesions are also there, and it has got a particular characteristic kind of lesion on the skin that is called the target lesions. Then a more severe form is known as Stevens-Johnson syndrome, where you have oral lesions, ocular lesions, and genital lesions. And the most severe form is known as the toxic epidermonecrolysis, okay, TEN, where the skin will just peel off from the skin will just peel off, just like a burn victim. You have to manage it. And the triggering factors, that there are 2 triggering factors for the occurrence of erythema multiforme. The first one is a viral infection. The second one is drug induced. So these things you can mention, like a half page if you can write. And the histopathology is not very characteristic. You're going to have a spongiotic kind of degenerative changes in the epithelial mesenchymal junction, and you're going to have a spacing in the epithelial mesenchymal junction with a lot of non-specific inflammatory infiltrate. So this much, and the treatment part is you have to identify the drug which is causing it, stop the drug, automatically the lesions will start reversing back. Okay, that's about erythema multiforme. The other questions that can come is, already we have mentioned about mucous membrane pemphigoid, paraneoplastic pemphigus. The other thing is discoid lupus erythematosus and systemic lupus erythematosus, both of them. Lupus erythematosus can be asked as a short essay or 5 marks question. Okay, so these are all the main questions that can be asked. Short notes, brief notes, like the 3 marks question, like all these signs, Nikolsky sign, Max-Stocer spaces, civet bodies, those things can be asked as short note, brief notes. And Auspitz sign. Auspitz sign is nothing but in psoriasis, when you're just in a skin psoriasis, when you peel off the overlying crusted areas, you will get pinpoint bleeding areas. That is what you mean by Auspitz sign. So those kind of things can be asked. And another way in which the question can be asked in a lichen planus is, lichen planus can be asked as a short note, a short 5 marks question. That is, they ask sometimes only the clinical and the histological features, or sometimes only the etiopathogenesis and the clinical and the histology. So something like that, only part of the essays can be asked as a short note. Another important question that you have to remember is about Sank cells. Already I have given you the whole scheme of how you have to write about the Sank cells. First or Sank smear, or the Sank smear as a technique. First you have to mention that Sank smear is nothing but it is just a cytological technique. Then you have to mention that what are the lesions in which you do a Sank test. Then you have to mention about the procedures, step-by-step procedures for a Sank test. Then mention about what are the cytological changes that you see in a Sank smear. Okay. So that's all for today. I hope I was able to do justice for you. Best of luck for all of you. So this is my department, like, my colleagues here in the department, and like the team, the whole team Annoor along with my department has helped us to organize this. I hope it is all beneficial for you. So thank you so much for your patient listening. Thank you.
Thank you, Deepu sir, for that wonderful presentation. And there is a question from Niranjana Menon. If classification is not asked, then should we write classification in the contents?
No need, but like usually for any essay question, like till now what we have seen is they will usually ask classification. Okay, because classification will carry around 2 marks or 2 marks or something they will ask. So usually they will ask classification. If it is not asked, don't have to write it. Don't waste your time writing classification. But usually, like if the classification won't be asked, if the lichen planus is being asked in your shortest, or in a 5 marks question, classification won't be asked. So don't write if it is not, you're not going to write it, don't write it in the contents if it's not going to write. The reason why we are writing it in the contents is because we want to draw the attention to the evaluator so that they will, okay, the person has written everything. Okay, immediately the marks will fall for it. Okay, so if it is not asked in the question, don't write it. Don't mention anything about it. Okay.
Thank you, sir. No more questions dropped in the chat box, and it was really an elaborative session on pemphigus, pemphigoid, and lichen planus. Once again, thank you so much. And we are moving on to the next session, that is on developmental disturbances. We are honored to have a renowned faculty, Dr. Jayanti Varun, for the final session of the day. Dr. Jayanti completed her BDS and MDS from Dr. MGR University and has received 3 gold medals during her undergraduation. She was the university topper in MDS oral pathology in 2007 and is currently working as professor at SCCI Dental College. She is so passionate about teaching and has trained more than 1,000 students for MDS entrance examinations in 5 different coaching centers across the country. She is also very much into research practices. With much happiness, I would like to welcome Jayanti ma'am for the session. Ma'am, please.
Thank you so much. At the outset, I would first like to thank the team oral pathology of Annoor Dental College, specifically Dr. Deepu and Dr. Priya, for giving me this opportunity to interact with all the students and give them my inputs on how to prepare and write the exam. I also thank the principal of the college, Dr. Jiju, and the management for creating such a good platform for the students, especially during this pandemic. Classes are not happening regularly in many of the institutions across the state and country, and the students are suffering a lot. So I think it's an ideal platform for the students to be benefited. So I really appreciate and congratulate the management and the principal for giving support to conduct such a program. So without wasting much of the time, I think we will move on to the topic. The topic given to me today is developmental disturbances. One good thing about this topic is you don't have the complicated histopathological diagrams to draw in this topic. Otherwise, when you talk about oral pathology exam itself, usually it is about draw diagrams, H&E diagrams. You get more marks when you draw the diagrams. But this particular topic is without drawing these H&E diagrams, there is no need for such diagrams. You can score good marks. And another thing about this topic, this is the first chapter in your Schaefer textbook. I think you all are aware of that. So what happens is even during the Viva, if you are not able to answer any other questions that the examiner asks, finally they'll move on to developmental disturbances, which means this is one basic topic which everyone expects you as third-year undergraduates to know. Okay, so not only from theory exam point of view, but also from Viva point of view, this topic is very important. It's also very voluminous and easy to forget. So I'll try to make it as simple as possible. Now, before we move on even to the topic itself, I just want to give small tips of how to prepare for the exam. See, what is more important is even before you go and write the exam, how you prepare for the exam is more important. So my opinion on this is that you first make a timetable. Now, for example, if you all are appearing in exam, say roughly in October or November, let's say the exam is going to be in November, you've got 2 months now, September and October. So what you need to do is you have to make a timetable. Now I have mentioned something called practical timetable, because there is no point in just making one timetable which you are not going to adhere or stick to it. So make a timetable that is possible for you. You know your shortcomings. You know how much time you need for reading. You know about yourself. So accordingly, you make one timetable for both these months. So every day you have to read one topic. So accordingly, you make and stick to that, so that in 2 months' time, you will be able to finish almost all the topic. And second thing is very, very important. Before you even start preparing, take the syllabus of the university. I think most of you are in Kerala Health University. So the syllabus is already uploaded in the website. So you take the syllabus, have it with you, and then only prepare, because your examination question paper will be strictly adhering to the syllabus. You will not get any questions out of the syllabus for undergraduate students. Therefore, there may be in the textbook one chapter called fungal infections. You may have 50 different fungal infections. It is not necessary for you to read everything. If you are interested, you can read. That's a different story. But today we are talking about examination, right? So when it comes to examination, questions will be asked only according to the syllabus. Therefore, keep the syllabus in your hand and know which topics are included in the syllabus, and accordingly you prepare. Then the next one is give equal importance to all the subjects. See, if in third year you have oral pathology, general medicine, and general surgery, when you make a timetable and read these 2 months, you cannot read only oral pathology and ignore the other 2 subjects. And even within oral pathology itself, you cannot just read developmental disturbances or skin chapter because myself and Dr. Deepu taught it. No, you have to give importance to all the chapters that are there in the syllabus. So give equal importance to all these subjects. And you know, for you, there may be some subject which you find it very difficult. That differs from each person. For me, especially when I was undergraduate student, general surgery was very difficult for me. I found it very difficult to remember the names of the instruments, the surgical techniques. So that was for me. But for my friend, general surgery was very easy. For her, oral pathology, remembering histopathological features was difficult. So each one of you will have something which you are weak in. Concentrate more on that. What you do is, if you are weak in that subject, you will omit it and try to avoid it. Don't do that. If you are weak and you know that, you have to focus more on the weak subjects. And very, very, very important thing is discuss with your friends. See, that is very, very important. See, what happens is when you sit alone and you try to read something, naturally what will happen after 5 minutes, you will want to check your phone, whether some WhatsApp messages have come, or you wanted to open Insta, you wanted to open Facebook. See, that is natural for anyone. It's for me or for anyone, it's the same thing. So what happens when you have a group study is that your concentration will be focused. Even if you don't want to do it, because you're sitting in a group, you will easily focus. You will not waste time. Okay. So if you have someone who is having a same wavelength as you, so you cannot do group study with everyone, right? You should have a same wavelength with your friends. You try to make a group of 2 or 3, sit together, discuss and study. That will really help you. Okay. And very, very, very important is revise and re-revise. That is a very important thing which I want to underline and emphasize, and because you don't expect that you read any subject or any topic just once, and then after that you can go directly to the exam, remember everything and write everything beautifully. No, maybe there are few who can do that. They are extraordinary people. Even me and Dr. Deepu, Dr. Priya, everyone, we have to keep reading it again and again, because the subjects are very volatile. Today you read it, you will remember. Next day you forget it. That's very common for every one of us. So try to revise and re-revise and read it again and again. Because many students, when I ask Viva, they come and sit and then they keep thinking for a long time. I said, what happened? You didn't read? No, ma'am, I read, but I forgot. That's the one answer I constantly hear from all the students. And I'll ask them one question. I think there may be some of my students also in this group. I'm not sure of it, but I usually ask my students this question. Now tell me, how many Malayalam and Tamil songs do you know by heart? I am pretty sure in this group, at least more than 100 songs you all would be knowing by heart. Not only in your own language, Malayalam, but also in Tamil, Hindi, English. Why, or how is that possible that you're able to remember the lyrics and tune of 100 different songs? That's because you keep hearing it again and again. Am I right? The same thing happens with any subject that you read. You have to keep reading and revising it again and again. That's how it stays in your mind. That's one point you have to fix, that you have to revise and read it all the time. And very important is you have to use good study material. Good study material in the sense, from where do you study? So the university is prescribing so many different textbooks like Schaefer and Neville, but most of the students end up reading a book called Mastering Third BDS. Now, I'm not going to tell you to read only Schaefer or read only. You can read any book which you are comfortable. Nothing wrong in it. Oral pathology is not going to change from whichever book you read. It's the same. But the only thing is, be aware that in some books like Mastering Third BDS or other textbooks, small textbooks, for each question, suppose if lichen planus, they give only 5 points for lichen planus. Oh, the problem is, if you read 5 points, when you go and write the exam, you will remember only 3 or 2 points. But what is the good thing about textbook is you will understand the concept. You will understand what is it. It is given like a story. So you will understand, if you understand the concept, it is easy for you to remember. And at least if you read 10 or 15 points, you will remember 5 or 6 relevant points and write. So that is the good thing about reading standard textbook. But again, I'm telling you, whichever you are comfortable and convenient with, you can read those books. Nothing wrong in that. Now that you have prepared for the exam, next thing is you have to present in the exam paper. You have to go and write your theory exam. So some tips for writing those exams. Very, very important is attempt all the questions. Always, if you leave any question, what some students do is they write the essay very beautifully. Suppose you get an essay from lichen planus, Dr. Deepu has taught you so well. So you're very confident. So you have spent, 1 hour and you've beautifully drawn the diagram, written everything. Okay. But what happened? You didn't have sufficient time for your short answers. So you couldn't attempt 3 or 4 short answers. And you have an idea. Anyways, I've written the essay very beautifully. So even if I leave 1 or 2 short answers, it's okay. No, it is not okay. Even if you very beautifully write all the points and nicely underline and follow all the tips, everything, out of 10 marks for the essay, maximum you will be getting is only 8 marks. No one is going to give you 10. No teacher is going to give you 10 out of 10. Otherwise, all of you will be scoring 100 out of 100 like mathematics in oral pathology, right? That never happens. So the maximum, I'm telling you, the maximum mark that you're going to be receiving for a very beautiful essay that you write is only 8 marks. But if you leave 3 short answers, already you left 9 marks. Okay. So definitely there is more chance that you're going to fail or you're going to score less marks. So never do that. You have to equally attempt all the questions, which means that you have 3 parts, right? You have essay, you have short answers, you have short notes. You have to allot 1 hour for each. So your total duration of your examination is 3 hours. You all know that. So write the essay for 1 hour, write the 5-mark question, short answers, short notes for 1 hour, and short answers for 1 hour. So you give equal importance and attempt all the questions equally. And write legibly and neatly. See, when I go for paper valuation, even though the content is not that great, but if it is written very neatly and underlined and nice, beautiful diagrams are drawn, then I have a good impression, right? So I'm not saying that content is not important, but I'm saying that whatever you write, try to write it neatly and legibly, and use flowcharts and tables. So Deepu told that when you write about the pathogenesis or etiology of lichen planus, instead of writing in paragraphs, you can avoid that. Your time is also saved and it gives you good impression also. So use flowcharts and tables and diagrams. Figures are mandatory for oral pathology. Any good answer you write without figures, you're going to get only half of the mark that you deserve. So figures, practice them again and again and try to draw nice, neat diagrams. Figures are really mandatory for oral pathology. And answer precisely. What does that mean? Is that read the question properly and answer only to that. See, one student asked, if classification is not asked in the question, should I write it? Don't write it. Don't write it at all. Just look at the question, read the question, what is asked in the question, only that you answer and attempt. Don't write unnecessary thing and waste your time. You're not going to get any marks for what you write. You're just only wasting your time. And again, I told you time management. Everything has to be given equal importance, all the questions to be answered. So keep in your mind, and for this time management only, we are keeping sessional exams and model exams in the department. So attend all those exams. That is for self-evaluation. That is for you to know whether whatever you have read at home, you're able to reproduce, remember and write it properly. And also whether 3 hours I'm able to manage and complete my paper. So that self-evaluation only is happening in your sessional exams and model exams. So take all those exams seriously, and then you will be happy with your time management. So with these few tips in mind, let's move to the next topic. My topic for today, developmental disturbances of teeth. Now, when this developmental disturbances of teeth is asked, usually the essay that is asked is about the disturbances affecting the structure of teeth. But I'm just going to give you an overview of everything. So this developmental disturbances of teeth can be grouped into 4 categories. One that is affecting the number of teeth, size of teeth, shape of teeth, and structure of teeth. So number of teeth, you all know deciduous teeth are 20 in number, permanent teeth are 32 in number for a normal individual. But what happens when number is affected? Either they can have less number of teeth, a person can have less number of teeth, or they can have more number of teeth. If you have less number of teeth than normal, that condition is what you call hypodontia. Hypo means less. Dontia refers to teeth. So hypodontia refers to less number of teeth than normal. That's because teeth are not developing. Some teeth may not develop properly. There is one very rare condition that's called anodontia. Anodontia means complete absence of teeth. So there is no tooth at all in the oral cavity. That's called anodontia. That's a very rare condition. The most common condition is hypodontia, that is less number of teeth. Exactly opposite of that. If you have more number of teeth, then that is called hyper. Hyper means more. More number of teeth is called hypodontia. That increased number of teeth is what you call supernumerary teeth. I think you all would have heard about this term, supernumerary teeth. That is the extra tooth that you have in the oral cavity is called a supernumerary teeth, and that condition is called hypodontia. So, hypodontia or less number of teeth, which tooth are most commonly missing in the oral cavity? This is an important viva question that's often asked for you. So, third molars, every one of you know that. Maxillary and mandibular third molars are most commonly missing. After that, the most commonly missing tooth will be your second premolars and maxillary lateral incisor. Now you can see from this picture here, this person has 2 central incisors in the maxillary arch, but both the lateral incisors are missing. After central incisor, they have only canine. So maxillary lateral incisor is one of the common tooth that is missing in a person if they have a condition called hypodontia. Now, this is an example. The second picture here is an example of hypodontia, where the number of teeth, many teeth are missing in the person's mouth. And when you talk about missing teeth, it can occur in a normal individual, or it can occur in a person who is having some kind of syndrome. So there are a number of syndromes where a person can have associated hypodontia. Don't have to remember all that. Whatever I have marked in red color, these 3 syndromes, please keep in your mind. Ectodermal dysplasia, chondroectodermal dysplasia, which is otherwise called Ellis-Van Creveld syndrome, and incontinentia pigmenti. These are the 3 conditions which are most commonly associated with hypodontia, out of which ectodermal dysplasia is very, very important. It comes under skin disease, where all the ectodermally derived structures are deficient, and you all know that teeth is also ectodermally derived structure. That is why in these patients, teeth will also be missing. So please remember that this will be very often asked in your viva question. And hyperdontia, I already told, is a condition where the person will have an extra tooth, and the extra tooth is called supernumerary tooth. So we have a classification for supernumerary tooth. You can classify supernumerary tooth in 2 ways. One is based on the location, that is in which part of the oral cavity you have that extra tooth. You can classify them into 3 types: mesiodense, distomolar, and paramolar. So you all know what mesiodense is. See the picture here. Between the 2 maxillary central incisor, there is one conical shaped, small sized extra tooth, which is erupted already. That's a mesiodense. Sometimes it may not be erupted. It may be impacted and stuck within the bone also. That's also possible. The second supernumerary tooth based on the location is your paramolar. So you can see in this picture, very small molar or conical shaped tooth, which is either present palatally or lingually to the existing molar. That's what is called paramolar. And the third one is the distomolar, which is also called fourth molar. That is, as the name itself suggests, it is present distal to the third molar. So anyone will have only 3 molars, right? First molar, second molar, third molar. Distal to the third molar, if you have an extra fourth molar, that is called distomolar. So based on the location, there are 3 types of supernumerary tooth. One in the midline between the 2 maxillary central incisor is the mesiodense. Palatal or buccal to an existing molar is called paramolar, and the fourth molar distal to the third molar is called as a distomolar. That is one way of classifying. The second way of classifying supernumerary tooth is based on the morphology, how the tooth looks like. You have three types: conical, tuberculate, and supplemental. So conical means this, I told you, mesodens is an example for a conical tooth. That is, it is not like a normal tooth, but it is just conical in shape. Tuberculate is, see this picture, where palatal to the incisors, you have an extra tooth. The shape is like a tubercle. Okay, that is called tuberculate. And supplemental is one example where you will have a tooth exactly resembling to a normal tooth. For example, instead of one lateral incisor, you may have two lateral incisor. The second lateral incisor is a supernumerary tooth. It's called supplemental tooth because it will look exactly like a morphology of a lateral incisor. That kind of supernumerary tooth, which has a morphology exactly similar to a natural tooth, is what you call a supplemental tooth. Now, in some textbooks or sometimes, even odontome is mentioned as a type of a supernumerary tooth. My personal opinion is, don't write odontome when a supernumerary tooth is asked as a question for you, because ideally odontome is an example for a odontogenic tumor. So there is something called odontogenic tumors where you study about ameloblastoma, adenomatoid odontogenic tumor. Under that category only odontome can be written. So when a supernumerary tooth is asked as a 5-mark or a 3-mark question, only write about mesodens, paramolar and distomolar. That is based on the location, and based on the morphology you have conical, tuberculate and supplemental. That will be more than enough. Okay. So this supernumerary tooth is very frequently asked 5-mark or 3-mark question. So be prepared for this question. So that's about the number of tooth, like how you have some syndromes associated with missing tooth, hypodontia. Similarly, there are some syndromes that are associated with supernumerary tooth or hyperdontia. So again, you have so many different syndromes, but just remember these two, which is important for Viva: cleidocranial dysplasia and Gardner syndrome. Now, this is very, very important Viva question. Any examiner likes to ask this question: can you name any two syndromes that are associated with multiple supernumerary tooth? Then the answer that you have to give is cleidocranial dysplasia, which is a bone disease, and Gardner syndrome. Okay, so that's why I have made that, I highlighted that two syndromes in red color. So all this time we were discussing about disturbances in the number of tooth. Next, we'll move on to the size of the tooth. So you have a normal size, it's fine. But if you have size smaller than the normal size, then you call it as micro. Micro means small dontia, and macrodontia means increase in the size of the tooth. Okay, so microdontia can be divided into generalized and localized. So what does that mean? Generalized and localized means, generalized means that all the tooth will be small in size. Then it is called generalized. But if only one tooth is small in size, then you call that as localized microdontia. The most common example for localized microdontia is peg laterals. Now again, many students think that peg lateral is a disturbance affecting the shape of the tooth because it looks abnormal in shape, right? No, it is not a disturbance affecting the shape of the tooth. Please remember, this is an example for localized microdontia. Therefore, peg lateral is an example for disturbance affecting the size of the tooth, not the shape of the tooth. So how will a peg lateral look like? So you can see the lateral incisor here next to the central incisor. It is small in size and it is not having a broad incisal edge. Instead of that, the incisal edge is narrow and conical. That is called as a peg lateral, which is the most common example for a localized microdontia. Same way, macrodontia can also be generalized and localized. Generalized means all the teeth will appear large. Why does that happen? It is very rare, but if it happens, that may be because of a condition called pituitary gigantism. So you all know what is pituitary gigantism. When the growth hormone is excessively produced, then that leads to a condition called pituitary gigantism. All the hard tissue and soft tissue of the body will be enlarged in size. So teeth also will be enlarged. So patient will have multiple teeth in the oral cavity. All of them are increased in size. That is generalized macrodontia. Localized macrodontia is only one tooth is increased in size. You can see in the picture here, this central incisor is appearing normal in morphology, but the size is very bigger than the adjacent tooth. That's an example for a localized macrodontia. So now, just for a recap, we have completed two disturbances affecting the teeth. One is the number of teeth. The second one is size of the teeth. Next, we will move on to the disturbances affecting the shape of the tooth. So you have 10 different things. Now, this sometimes can be asked as an essay question for you. So the question may be like, enumerate the developmental disturbances affecting the shape of the tooth and write in detail about each of them. So what you have to do, you have to understand the question. The word enumerate means that first you have to list down all the developmental disturbance affecting the shape of the tooth. That's what I've done here. Number 1 to number 10. First list down everything. Then about each of it, you have to write few points. Okay. So gemination and fusion is almost similar in appearance. It will appear as a double teeth. So you can see the picture here. These teeth are appearing as if there are two crowns which are stuck to each other, okay? Right? That kind of clinical appearance is called double teeth. So when you have double teeth clinically, it can be either gemination or it can be fusion. So how are you going to differentiate? That time what you need to do is you have to count the number of the teeth present in the oral cavity. When you're counting the number of tooth, this double tooth has to be counted as one tooth. So this is number 1, then number 2, number 3, like that. Count all the teeth in the oral cavity. If all the teeth are having only 32 number, totally only 32 you get, the normal number you get, then it is gemination. But when you count all the teeth in the oral cavity and one number is missing, that is instead of 32, you have only 31, number is less than normal, then it is fusion. This is the best way to differentiate between gemination and fusion. That is, you count the number of teeth in the oral cavity. You have to take the double tooth as number 1, and then you count all the teeth in the oral cavity. If you get normal number, like a normal person, then it is usually a gemination. But if you have less number of teeth than normal, then it is fusion. Concrescence is again joining of two teeth, but the joining happens only at the level of cementum. So you can see from the picture here, only the roots are fused with each other. Crown is not fused. So if the two teeth, adjacent teeth, are fused at the level of cementum, then you call that as concrescence. Dilaceration is a bend or curve in the, usually the root. Sometimes it can also happen to the crown. What is the problem with dilaceration? When it is curved or bent, you have to be very careful when a root canal treatment is done. If you don't do it properly, you can see from the picture or radiograph here, only till here the filling is done. The curved portion of the root is not filled. So patient will come back with pain again. Or if you have to extract the tooth, this curved portion will break. So it's very challenging to do extraction or root canal filling if a tooth is dilacerated. So when you're writing about a particular condition, don't just write what dilaceration is. What is the clinical implication of that also has to be mentioned in the answer. Dense invaginatus can be asked as a 3-mark question for you. Very important. It is also having another name called dense in dense. Dense in dente means tooth within tooth appearance. So why do you have the tooth within tooth appearance? Because the enamel is getting invaginated. So when you take a radiograph, it will look like as if another tooth is present within an existing tooth. That is why the other name for dense invaginatus is called dense in dente, which means that tooth within tooth appearance. So based on the invagination, 3 types of dense invaginatus have been described. You can see from the picture here. Please draw this diagram when dense invaginatus question is asked. Very, very important. In the first type 1 invagination, the invagination is extending. This is enamel, dentine, and the red color is the pulp. So in the first type of invagination is extending only from enamel into the dentin. In type 2 dense invaginatus, the invagination is extending from the enamel into deeper part of the dentin, but it is not touching the pulp. Okay, but it is in direct line with the pulp, but it is not touching the pulp. Whereas in type 3 invagination, from the crown portion, the invagination is extending beyond the cervical portion of the tooth and into the root portion it is extending. Therefore, a direct communication is seen from the crown to the apical portion of the root. That is a severe form of invagination which is type 3 invagination. So the invagination itself depends on the depth, can be classified into 3 types: type 1, type 2, and type 3. That is dense invaginators. What is exactly opposite to that is dense evaginators. Evaginators means outward projection. So the dense evaginators can also be called as accessory cusp. Accessory cusp means additional cusps. So the additional or accessory cusp, other name is dense evaginators. So we have 3 types of dense evaginators that has been described. The first one is an additional cusp or an accessory cusp, which is seen in the maxillary first molar. You all know that. That's called cusp of Carabelli, which is seen in the lingual aspect of the mesiolingual cusp. So this is the maxillary first molar. Amalgam filling is there in this too. This is the mesiopalatal cusp. Lingual to the mesiopalatal cusp, you have an additional cusp here that is called cusp of Carabelli, which is a characteristic or unique feature of maxillary first molar. That's the first example for accessory cusp. The second example is called talons cusp. You see it exclusively in the anterior tooth. You don't see it in posterior tooth. In the lingual aspect of anterior tooth, incisors and canines, you can see a projection here. Yes, because it is resembling an eagle's talon, it is called as talons cusp. Okay, that's a second example. The third example is seen in the occlusal aspect of a premolar. So on the occlusal aspect of premolar, you generally see only 2 cusps, a buccal cusp and the lingual cusp. But here you see an additional projection on the central part of the occlusal aspect of the maxillary or mandibular premolar. That is an example for an accessory cusp, which is also called Leong's premolar. So Leong is a person who first described this condition. So it is also called as Leong's premolar. So just to summarize, dense evaginators is a condition where an extra projection or a cusp is seen on the tooth. So it is also, this condition is also called accessory cusp. We have 3 examples for accessory cusp. One is cusp of Carabelli, which you see on maxillary first molar. The second one is talons cusp, which you see on the lingual aspect of an anterior tooth. And the third one is Leong's premolar, which you see on the occlusal aspect of a premolar. The another 3-mark question that is frequently asked in your exam is taurodontism. So if a question is asked taurodontism, first write that taurodontism is a condition affecting the shape, developmental disturbance affecting the shape of the tooth. That's the first line you have to write. So what will happen here? The crown will be enlarged. Okay. Also, the root will have a defect. So what is the defect that is present in the root? The bifurcation or trifurcation of the root is pushed to the apical part of the root. So this is a normal tooth. See how the tooth is. It's a mandibular molar. You have 2 roots in this molar, and the bifurcation of the root is almost half of the root, correct? But see, in this particular tooth, the bifurcation is pushed to the apical part of the tooth. That condition is called taurodontism. So what is affected here? Both crown and the root morphology is affected. So what is the problem with the crown? The crown is bulbous and enlarged, and it is rectangular in shape. The normal cervical constriction of the crown is absent. It is enlarged, bulbous, and having rectangular shape. That is the problem with the crown. What is the problem with the root? The bifurcation of the root is pushed towards the apical part of the tooth. That is the problem with the root. So based on the severity, you have 3 types of taurodontism: hypotaurodontism, mesotaurodontism, and hypertaurodontism. So you can see from the picture here. So hypertaurodontism means the severity is increased, whereas hypotaurodontism is a mild form of tooth. This is the normal tooth, which is not affected with taurodontism. So why this problem happens? That's because this problem is happening because the Hertwig's epithelial root sheath is not bending at the right level. So you remember from your first year histology, right? Like how this epithelial diaphragm and Hertwig's epithelial root sheath, one horizontal bend has to happen. Only then the normal development of roots will happen. But here in some individuals, this epithelial diaphragm and Hertwig's epithelial root sheath is not bending at the right level. And that is why this kind of appearance you get. And why is it called as bull-like tooth? The other name is bull-like tooth. Why is it called bull-like tooth? You can see from the picture here. Many students give the answer because the tooth is big, enlarged. That's why you call it bull-like tooth. I will ask the students, if the tooth is enlarged, you can call it elephant tooth, right? Why do you have to call bull-like tooth? It is not because the tooth is enlarged? It is because the tooth is resembling like a tooth of a bull. Not because the tooth is enlarged, you call it as a bull-like tooth. Taurodontism is otherwise called bull-like tooth because the affected tooth will resemble the tooth of a bull. That is why it's called bull-like tooth. Okay. So that's about taurodontism. Now, so we have described about all the developmental conditions affecting the shape of the tooth, number 1 to number 10. Okay, so remember, say about each of it, draw a diagram for each of it, and tell about the clinical implications. Out of all this, separately, taurodontism is very, very important. Dens invaginatus is very important. These two questions can be asked as a 3-mark question. So at least 3 or 4 relevant points you have to remember, draw a diagram and write. Suppose if taurodontism is asked, first write taurodontism is a developmental disturbance affecting the shape of the tooth. So both crown and root morphology is affected. In the crown will appear bulbous and enlarged. The cervical constriction will be absent. So the tooth will have a rectangular appearance. Because it is resembling the tooth of a cut-chewing animal or a bull, the other name for taurodontism is bull-like tooth. The root morphology is also affected because the Hertwig's epithelial root sheath and epithelial diaphragm are not having a proper horizontal bend. Therefore, the apical portion of the bifurcation of the tooth is pushed to the apical portion of the root. So both crown and root morphology is affected. Based on the severity, 3 types of taurodontism have been described: hypo, meso, and hypertaurodontism. These are the 5 points you have to write about this particular condition whenever it is asked. Okay. So the last one, and very frequently repeated as an essay question for you, is developmental disturbance affecting the structure of tooth. So many students get confused between shape of tooth and structure of tooth. Shape means morphology. Morphology means what? For example, taurodontism, the shape of the molar is lost. It is appearing like a bulbous root. Okay, but the normal enamel dentin pulp and all is normally formed. It is not affected. The structure is not affected, but the morphology and shape is affected. That is what we discussed all this time. But what we are going to discuss now is the disturbances affecting the structure of tooth. So structure of tooth means what? Tooth is made up of what? Crown is lined by enamel dentin and pulp. Root is covered by cementum dentin and pulp. If any of these structures are not formed properly, then it affects the structure of tooth. So when a question is asked like this, enumerate the developmental disturbances affecting the structure of tooth, write in detail about enamel hypoplasia. This is the most frequently asked question for you. Enumerate the developmental disturbance affecting the structure of tooth, write in detail about enamel hypoplasia. If a question is asked like that, first, how will you write? Don't just list down. The simplest way of understanding this is, I already told you have different structures in the tooth: enamel, dentin, pulp, cementum. So you have to divide or classify into which structure is affected in what condition. That's what this picture shows, this slide shows. So if there is a condition affecting only enamel, then you have two conditions under that. One is called amelogenesis imperfecta. The second one is called environmental enamel hypoplasia. Or in other words, a developmental disturbance affecting the structure of enamel is otherwise called enamel hypoplasia. That's a common term that we use. So what is enamel hypoplasia? It's a developmental disturbance affecting the structure of enamel. This enamel hypoplasia can be of 2 types. Either it can be hereditary or it can be environmental. Hereditary enamel hypoplasia is otherwise called amelogenesis imperfecta. So the term amelogenesis imperfecta is used for hereditary enamel hypoplasia. Whereas if you get enamel hypoplasia due to other causes, not because of hereditary condition or genetic condition, but because of environmental causes, then you call that as environmental enamel hypoplasia. So these are the 2 conditions affecting the structure of enamel. The conditions affecting the structure of dentin, you have 3 conditions: dentinogenesis imperfecta, dentin dysplasia, dentin hypocalcification. Both enamel and dentin, both are affected, then that condition is called regional odontodysplasia. Odonto means teeth. So regional odontodysplasia is a condition that affects both enamel and dent. So you have to classify like this. For you also, it is easy to understand and remember. For people, for teachers who are correcting also, they will know that you have understand the subject. So write it like this, okay? Developmental disturbance affecting enamel would be 2, amelogenesis imperfecta, environmental enamel hypoplasia. Those conditions affecting dentin would be dentinogenesis imperfecta, dentin dysplasia, and dentin hypocalcification. Condition affecting both enamel and dentin, and to some extent pulp also, is regional odontodysplasia. So I already told you about amelogenesis imperfecta. It is otherwise called as hereditary enamel hypoplasia. So why is it called hereditary enamel hypoplasia? Because enamel is not formed properly. Why enamel is not formed properly? Because genetically there some genes are getting mutated. Because of the mutation of the genes, enamel is not formed properly. So because this is a genetic disorder, it can get transmitted from one generation to the other generation. That is why it's called hereditary. So you have to understand the difference between genetic disease and hereditary disease. What is the meaning of genetic disease? If a particular disease is occurring because of mutation in a particular gene, then you call that as a genetic disease. So in amelogenesis imperfecta, there is mutation in AML gene. So amelogenesis imperfecta is a genetic disease. What is hereditary disease? Hereditary disease means if a mother or father is affected, there is a chance that it can be transmitted to the son or the daughter. So it can be transmitted from one generation to the other generation. Then you call that as hereditary disorders. So most of the hereditary disorders are genetic disorders too. Okay, so amelogenesis imperfecta is also a genetic disorder. It is also a hereditary disorder. Both are correct. It is called genetic disease because it is caused by mutation of a gene. It is called hereditary disease because it can be transmitted from one generation to the other generation. Okay. So there are so many different types of amelogenesis imperfecta, and each type of amelogenesis imperfecta will have different type of clinical manifestations. But you need to understand that both deciduous dentition and permanent dentition will be affected in this condition because the affected gene is present in the person. So even the milk teeth will be affected and permanent teeth will be affected. So we know that enamel formation happens in 3 steps. In first year histology, you all would have studied about amelogenesis, formation of enamel. It happens in 3 steps. First, the organic matrix will be formed. Then in the second step, mineralization will happen. And in the third step, maturation will happen. Correct? So when amelogenesis imperfecta is occurring, it can affect any of these 3 steps. Accordingly, we have 3 types of amelogenesis imperfecta. If enamel matrix formation, if the first step is affected, then that type of amelogenesis imperfecta is called hypoplastic type. If mineralization is affected, then that type you call it as hypocalcified type. If maturation is affected, then you call that type as hypomaturative type. Therefore, we have, according to Wittkopf is a scientist who first classified amelogenesis imperfecta. So according to Wittkopf, when you classify amelogenesis imperfecta, there are 4 types of amelogenesis imperfecta. Type 1 is called hypoplastic. Type 2 is called hypomaturation. Type 3 is called hypocalcification, and type 4 is a combination type. Combination type means both hypoplastic and hypomaturation will occur together. That's called type 4. So this classification is very important. So these 4 types of amelogenesis imperfecta has to be mentioned if this is asked as a essay. So the first type is hypoplastic type, where formation of enamel matrix is affected. The second type is hypomaturation type. The third type is hypocalcification type, and the fourth type is combination of hypoplastic and hypomaturation type. Okay. So each of this type will have different clinical features and they have different pattern of inheritance. What do you mean by different pattern of inheritance? When you have the disease transmitting from one generation to the other generation, it can be autosomal dominant pattern of inheritance, autosomal recessive, X-linked dominant, X-linked recessive. So each type has different pattern of inheritance and different clinical features. So as I already mentioned, there are different genetic studies that have been done, and they say that the important gene that is mutated in amelogenesis imperfecta is AML gene. This AML gene is coding for amelogenin protein, and that is present in the X chromosome. So in the humans, we have X chromosome, right? So within this X chromosome, there is one gene called AML gene, AMEL. This AML gene codes for a protein called amelogenin that is present in the enamel. So if that AML gene is undergoing mutation, then amelogenin will not be formed properly. As a result of that, you will get amelogenesis imperfecta. So that is one important genetic study that has been done, and this is the result they have got out of the study. So all this time we were talking about the hereditary type of enamel hypoplasia, which is there is a problem in the gene and the disease is getting transmitted from one generation to the other generation. That's called amelogenesis imperfecta. But the enamel will not be formed properly because of other environmental reasons. What are the conditions in which enamel will not be formed properly? You have 8 different etiologies because enamel will not be formed properly. All this you will not call amelogenesis imperfecta. The term amelogenesis imperfecta is strictly restricted only to hereditary type of enamel hypoplasia. If enamel hypoplasia is occurring due to any other cause other than hereditary, then you will call that as environmental enamel hypoplasia. So what can be the causes? It can be because of nutritional deficiency, especially calcium, because calcium is necessary for mineralization of enamel. Because of vitamin D, because vitamin D controls calcium metabolism. Okay, because of nutritional deficiencies, because of exanthematous diseases. If a child during the tooth development gets viral infection like chickenpox, measles, cytomegaloviral infections, these viral infection can affect the formation of tooth and enamel specifically. So those children can have enamel hypoplasia in a erupted tooth. That is what is called exanthematous disease. It's called exanthematous disease because in disease like chickenpox and measles, the patient will have skin eruptions. So exanthema means skin eruption. That is why chickenpox and measles are otherwise called exanthematous fever or exanthematous diseases. So in that condition also enamel hypoplasia will occur in the tooth. Due to congenital syphilis. In congenital syphilis, you will get enamel hypoplasia, and especially this is affecting 2 teeth. Maxillary central incisor, that is called Hutchinson incisor, and the second tooth it will affect is your molar, where the molar will have a mulberry appearance. So it is also called mulberry molars. So in congenital syphilis, which is a sexually transmitted disease, but in this condition, the pregnant mother is transmitting the infection to the child. So the child will be born with the infection. So when the child is born and the tooth is erupting, usually the central incisor will have a screwdriver shaped appearance. That is called Hutchinson incisor. Enamel is not formed properly there. And the molars will have mulberry appearance. That's called mulberry molars. Hypocalcemia, I already mentioned, because calcium is necessary for mineralization. You get enamel hypoplasia there. Sometimes because of trauma also, you will get enamel hypoplasia. If you have enamel hypoplasia in a single tooth, only in one tooth, that is because of trauma or infection in that particular tooth, that type of enamel hypoplasia is specifically called Turner's hypoplasia. Again, this is a very, very important Viva question. If someone asks you what is Turner's tooth or Turner's hypoplasia, the answer you should give is a single tooth affected with enamel hypoplasia because of either a trauma or infection, then you call that hypoplasia as Turner's hypoplasia, and that tooth is called Turner's tooth. So which is most commonly affected? If it is trauma, then it is maxillary incisor. If it is because of infection, then it will be your premolars. Okay? So if you have a deciduous molar that is having infection, then the erupting premolars will get enamel hypoplasia. That is called as a Turner's tooth. So a localized infection or trauma can produce enamel hypoplasia in a single tooth, that is called Turner's hypoplasia. Excessive fluoride in drinking water can get deposited in a developing enamel, and that can also result in enamel hypoplasia. That is called fluorosis, dental fluorosis. And this is very, very important because it not only causes enamel hypoplasia, but it is also getting deposited in the bone, and self-fluorosis can also happen in this case. So these are the various causes because of which enamel will not be formed properly. All these are examples for environmental enamel hypoplasia. So please understand the difference between hereditary enamel hypoplasia and environmental enamel hypoplasia. The term enamel hypoplasia refers to enamel is not formed properly. That's all. Why it is not formed properly? If it is because of hereditary condition, then you will use the term amelogenesis imperfecta. But if it is because of environmental causes, then you will call it environmental enamel hypoplasia. Next, we will move on to alterations or disturbances in the dentin development. So two important questions, both are important, can be asked as a 5 mark. One is dentinogenesis imperfecta, the other one is dentin dysplasia. So like amelogenesis imperfecta, same thing, concept is the same, only the name is different. Amelogenesis imperfecta means enamel is not formed properly because of genetic mutation. The same thing, if dentin is not formed properly because of genetic mutation, then it is called dentinogenesis imperfecta. Simple. Okay. So it's a hereditary condition affecting the formation of dentin due to genetic mutation of a particular protein present in dentin. So it is otherwise known as, this condition is otherwise called as hereditary opalescent dentin, because when you clinically look at the tooth, it will have a opalescent appearance. So the other name for dentinogenesis imperfecta is hereditary opalescent dentin. So there are two types of classification. If you see older textbooks, that is called Shield's classification. According to Shield, 3 types of dentinogenesis imperfecta was there: type 1, type 2, type 3. But now they have revised this classification. In the recent classification, we only have 2 types of dentinogenesis imperfecta, type 1 and type 2. Okay. So the previous classification, type 1 and 2 clubbed together and it is made it as type 1. And the type 3 is now called as type 2. So this change in the classification, everyone should be aware of. Very, very important. The newest classification of dentinogenesis imperfecta, you only have 2 types, type 1 and type 2. In type, what is the difference between type 1 and type 2 is that in type 1, abnormally increased amount of dentin will form. Excessive dentin will be formed. That is all abnormal. They are not normal dentin. Abnormal increased amount of dentin will form. Therefore, the pulp chamber and the root canals will be very narrow. When you take a radiograph of the tooth and see, which is affected with type 1 dentinogenesis imperfecta, you can see that the pulp chamber and the root canals are very narrow. Why? Because of increased deposition of abnormal dentin. That is type 1. Whereas in type 2, exactly opposite happens. The dentin will be very thin. Therefore, the pulp chambers and root canals will become very bulbous and enlarged. Exactly opposite. Therefore, type 2 dentinogenesis imperfecta is otherwise called as shell teeth. Why you call it as shell teeth? Shell means what? Ode. Ode is called shell. So it is called shell teeth because a thin layer of enamel and a thin layer of dentin will be seen, and the pulp chamber and root canals will be enlarged and bulbous. This is the appearance you have in type 2 dentinogenesis imperfecta. Because of a thin dentin and enamel, this tooth is otherwise called shell tooth. So in the 3-mark question, sometime the question can be asked as shell tooth. Do not blink. Don't think that, ayo, what is this? I have not read about it. This is the other name for type 2 dentinogenesis imperfecta, where a thin layer of dentin is formed, as a result of which the pulp chamber and root canal will appear bulbous and enlarged. This is otherwise known as shell teeth. Okay. So this is the newest classification or revised classification, which you have in the textbooks. Even in Schaefer, it is mentioned. So I told you about shell tooth, right? So you can see the radiograph here. See the black hair area that you see in the radiograph, that is the enlarged and bulbous pulp chamber and root canals that you have. The dentin and enamel will have a thin covering here. So please remember, enamel is not abnormal here. Enamel is little bit normally formed. There is no problem with the enamel here. In dentinogenesis imperfecta, the problem is only with dentin and the pulp morphology. Enamel is normally formed, but I am using the word thin layer of enamel because otherwise also enamel is only thin. You don't have a thick layer of enamel on the tooth. The bulk of the tooth is generally made up of dentin only. Enamel will always be very thin. Therefore, when you take a radiograph of a teeth affected with dentinogenesis imperfecta type 2, a normal thin layer of enamel will be seen. And then you have a thin dentin and an enlarged pulp chamber. That's what you call shell tooth or shell teeth. Dentin dysplasia is again a hereditary or developmental disturbance affecting the formation of dentin. Here also atypical or abnormal dentin is formed and abnormal pulp morphology is seen, but enamel will be normal. Please remember this very, very clearly. Both in dentinogenesis imperfecta and dentin dysplasia, enamel is normal. Only dentin and pulp morphology is affected. Okay. Now I am telling you that dentinogenesis imperfecta on one hand, dentin dysplasia on the other hand. What is common for both? Both are developmental disturbance affecting the formation of dentin. Both are hereditary conditions. Both are having genetic mutation. Then what is different in both? The difference is the type of gene that is mutated is different. That is why we are giving two different names, as a result of which the clinical appearance also will be different. Otherwise, the common feature for dentinogenesis imperfecta and dentin dysplasia is that both are developmental disturbance affecting the structure of dentin. Both are hereditary disorder characterized by genetic mutation in dentin proteins. That is common to both the disease. The difference is that the gene that is mutated will be different. As a result of that, the clinical appearance of the disease will also be different. So the gene that is mutated in dentinogenesis imperfecta is dentin sialoprotein. Whereas in dentin dysplasia, dentin phosphoprotein is affected. So the type of genes are different. Okay, only that you remember for your understanding. And like how in dentinogenesis imperfecta, we have two types in the revised classification, type 1 and type 2. Type 2 is otherwise called shell teeth, right? Same way in dentin dysplasia also, we have two types of classification, type 1 and type 2. In type 1, only the root dentin is affected. So it is otherwise called radicular dentin dysplasia, that is type 1. Whereas in type 2, crown dentin is affected. So it is called coronal dentin dysplasia. That's the difference. So remember that dentin dysplasia is of two types. Type 1 is radicular dentin dysplasia, where only root dentin is affected. So sometimes the root may be totally absent. That is why the other name for dentin dysplasia is rootless teeth. If you see in the textbooks, it is mentioned in bracket as rootless teeth. Why you call it as rootless teeth? Because in type 1 or radicular dentin dysplasia, root dentin is not formed properly. So that particular tooth root itself may be absent in severe cases. So it is otherwise called rootless teeth. So the other name for type 1 dentin dysplasia is rootless teeth. Whereas in type 2, only the crown dentin is affected. So it's called coronal dentin dysplasia. And this has some similarity between dentinogenesis imperfecta. That is both dentinogenesis imperfecta and coronal dentin dysplasia. The crown portion of the tooth will be affected, where the tooth will have opalescent appearance. Opalescent means the dentin will have an opalescent appearance. The tooth will have a bluish tinge. Normally, the tooth will be grayish white or white in color, right? When you look at it. But in coronal dentin dysplasia and dentinogenesis imperfecta, clinically, when you look at the tooth, you will have an opalescent or translucent appearance of the tooth. That is because the formation of the crown dentin is affected. Okay, now coming to the last part in developmental disturbance affecting the structure of tooth is regional odontodysplasia. You remember that I showed you in the list of diseases. The last one, regional odontodysplasia, is the condition affecting both enamel and dentin. Most of the time in examination, this question is asked as ghost teeth. No one asks about regional odontodysplasia. The most popular term to describe that condition is ghost teeth. So if a question is asked as ghost teeth, how will you answer that question? Because this is very, very frequently asked. Almost every question paper, if you check old question papers, you take 5 years question paper from Kuhas and check it. Almost every year, you get this question, 5 marks question, ghost teeth. So when a question is asked ghost teeth, plus first remember that it is nothing but it is the other name for regional odontodysplasia. And you know that regional odontodysplasia is a developmental disturbance affecting the structure of teeth, where both the formation of enamel and dentin is affected. This is the first thing. Now, in this particular question, what I'm going to do is I'm going to show you how you will write the answer. All this time, I was trying to explain to you about each of the disease. But this ghost teeth I've taken as an example, and I'm going to show you in your university theory paper, if a question is asked about ghost teeth, how will you approach and answer that question? That's what I'm going to show you now. So when a ghost teeth is asked as a 5-mark question, so what are you expected to write? First thing, you have to write an introduction. Introduction means first write what is ghost teeth. It is otherwise called as regional odontodysplasia. That's the first statement you will write. What is it? It is a localized developmental abnormality affecting the structure of enamel, dentin, and pulp. See, this is very, very important because most of the time when I go for paper valuation, so I'm doing this for more than 15 years. So many different papers I have corrected. Most of the time when a question is asked ghost teeth, I go and see the answer. Students, first of all, will not have time for 3 marks, and also they'll just scribble something and write. And what will they write is, ghost teeth is the radiographic appearance. Ghost-like appearance of the teeth will be seen. Don't write the answer randomly. You have to always organize the answer and write it. See, this is very, very important. One point you have to remember, in your class, the topper who scores the highest mark in oral pathology, they are also reading the same textbook what you are reading. The same teachers we are teaching is teaching for everyone uniformly. Yes. But why they are able to score better than the other people? It is not because they are studying and retaining. That is one thing. Second thing is how you present. If 100 people know the answer also, how you are presenting that answer is very, very important to score marks in the exam. The same points, whatever you know, if you write it in an organized way, neatly and legibly, underline the important points, and then you will get a better mark. And that is what I'm going to show you now. How are you able to do that? How are you going to do that? So first, always write an introduction. If a lichen planus is asked as a question, don't start by writing that in lichen planus sawtooth retiridge will be seen. Don't write that as a first statement. Always write one introduction. What is lichen planus? Lichen planus is an autoimmune skin disorder that will affect both skin and oral cavity. That's the first statement you will write, right? Same way, if a question is asked about ghost teeth, just write, it's a localized developmental disturbance affecting the structure of enamel, dentin, and pulp. It is also called as regional odontodysplasia. That's the introduction you will write. The next thing you will write is etiopathogenesis. Why this enamel and dentin is not formed properly? There should be a reason for that, right? What is the reason? The exact reason we don't know. The exact cause is not known, but there are some proposed etiologies. Proposed etiology means possibility. Maybe it is because of this. Maybe it is because of that. Like that, few people have done studies and proposed some causes. So what are the proposed causes? It may be because of some mutation of some gene. That is one possibility. Or it may be because of some viral infection, that enamel is not formed properly. Or it may be because that the vascular or blood supply to the tooth is not happening properly. So these are the various causes that have been proposed, but the exact etiology is not yet found. So that is the thing you have to write under etiopathogenesis. Next, you have to write about clinical features. Next heading is clinical features. In clinical features, you need to first write which age group is affected. Whether males and females are affected differently. Which part of the tooth is affected, maxillary teeth or mandibular teeth. Okay. Then how it will look clinically. So in any type of lesion that you write, in clinical feature, these are the 4 points we will look for. Age group, gender, which part of the oral cavity is affected, how will it will appear clinically. So in regional odontoblasia, the age of diagnosis is very young age, children, 2 to 4 years or 7 to 10 years. Okay. Slight female predominance is noted. Maxillary teeth are more affected than mandibular teeth. In the maxillary dentition itself, central incisor, lateral incisor, and canines are commonly affected. Both permanent and deciduous teeth are affected. What will be the clinical feature? The most common clinical feature will be the tooth will not erupt. That's the problem. Failure of eruption or delay in eruption of the tooth. Even if it is erupting also, the crown will have an irregular shape, and the color of the tooth will have yellow to brown in color. That will be the clinical appearance of the tooth. Because of the radiographic appearance only, the name ghost teeth is given. So why the name ghost teeth is given for regional odontodysplasia? Because radiographically it have ghost-like appearance. So the next question is, how will a ghost appear? Has anyone seen how a ghost will look like? None of us have seen. I have not seen. So I don't know if any of you have seen or not. But in movies, just imagine, either it is in Malayalam movie or Tamil movies, if you would have watched horror movies, when they are showing a ghost, okay, how will they show? There is one white color appearance which is moving. There is no feature or morphology for that white structure, but it is just moving in the air like that. That's how traditionally ghost was shown, right, in movies, and how we imagine. Because the ghost is not having any appearance. The ghost is not having any appearance. It is only having a white irregular outline. That is what we imagine in our mind as ghost. Same way, the tooth that is affected with regional odontodysplasia, when you take a radiograph, will only have a wispy image of the enamel and dentin. It will not have the normal morphology and shape of a tooth. But radiographically, the enamel and dentin will be very thin and only a wispy image of that enamel and dentin will be seen. And that is why this condition is called as ghost teeth, because the proper normal morphology of the tooth is missing. And also the roots will be very short with open apexes. You can see the picture here, radiographic picture. A thin enamel and dentin, enlarged pulp, only a wispy image of the tooth is visible. The roots are very short with open apex. This will be the radiographic appearance. And so radiographically, it is called as ghost teeth. Then don't forget to write about histopathology. The subject itself is oral pathology. Your answer will be incomplete without writing histopathological features. So even in ghost tooth, when you look under the microscope, what will you see? You will have abnormality in the enamel, dentin, and pulp. In the enamel, what will you see? Irregular structure of enamel rods. In dentin, what will you see? Irregular structure of dentin. And in pulp, you will see large areas of pulp stones. So all the three structures, abnormality will be detected. Along with that, very, very important is you will see some round structures surrounding the unerupted tooth. They are called enameloid conglomerates. This is one point you have to underline. As Deepu told, there are some terminologies which are very catchy, which the person who is correcting the paper will expect in the answer sheet. Therefore, write this point and underline it or write it in a red color pen or pencil. Enameloid conglomerates. What is enameloid conglomerates? Around the unerupted tooth, you will see enamel-like abnormal structures, epithelial structures. That is called enameloid conglomerates. Enameloid means something which is resembling enamel, will be seen surrounding the unerupted tooth. That is seen histopathologically if you see under the microscope. Then last one is you have to tell about the treatment. Treatment, the answer is not complete without treatment. What is the treatment? There is no specific treatment because already the tooth is abnormal morphology, roots are very short. So you have to just extract the abnormal tooth and give them a replacement. So artificial tooth has to be given either implants or bridge or removable partial denture, whatever is possible, you can give that. So this is just an example for you. If a 5-mark question is asked about ghost teeth, don't randomly write one paragraph or 4 to 5 lines about ghost teeth. Try to organize it properly under 5 different headings. The first heading is introduction, second is etiopathogenesis, clinical features, radiographic features, histopathological features. So 5 headings you give, and under each heading write 3 points. You don't have to write any stories. Just write 3 relevant points and underline the important points. Maybe if I am the person, I will give 5 out of 5. Because I'll be so impressed with this answer that every possible thing you have organized it properly. You have not left any important points. You have mentioned everything. So I'll be really happy that I'll give either 4.5 or 5 for this answer if you write it in this way. Okay, so try to organize your answer. That is the most important thing. However, how much ever you know, if you are not able to reproduce it in a good way, there is no point of reading it. So what you need to do is you have to prepare previously itself. That is why I am telling you, take the old question paper and see what are the questions that are frequently asked. Prepare the answer before only and keep. Because there you cannot go and think, what should I write? Should I write this? Should I don't write this? You don't have time for all that. So previously asked repeated questions, you prepare the answer and you know, these are the headings I have to cover. These are the points I have to mention in this topic. So you be prepared, and the same way if you go and write it, definitely I am 100% sure you will all pass in first class. Okay, so this only for an example, I gave ghost teeth as an example, and this is a very vast topic. The time given for me was only 45 minutes. I didn't want to take much of your time. That's why I quickly gave an overview of everything. And the same way how I approached ghost teeth, the same way only you're supposed to write all the other answers also. This is just an example I'm putting. Okay, so we have come to the end of this topic. Again, I would like to thank Dr. Deepu, Dr. Priya, and all the other staff members, management, and Principal Dr. Jiju of Annoor Dental College for organizing such a wonderful program that will be beneficial for the students. And I would also like to thank all the students for taking your time and participating in this program. It's really a pleasure to interact with all of you. So many of you have registered, and though it is a Sunday, you all have come and attended this program. It shows your interest to learn. So I really appreciate your effort taken. If there are any doubts, I'll take 5 minutes and clarify. Otherwise, I think we can just log off.
Yes, ma'am. There is 2 doubts popped up here.
Yeah.
One is when classification of developmental disturbances affecting structure of teeth is asked, do we need to mention the classification of amelogenesis imperfecta and dentinogenesis imperfecta?
No, see, that is what, as I mentioned before, read the question carefully. The question asked is, classify the developmental disturbance affecting the structure of tooth. That is the question, for which maybe you will have 2 marks. And then the remaining part will be described in detail about enamel hypoplasia. So you don't have to write about the classification of dentinogenesis imperfecta and amelogenesis imperfecta in that. Only write the first thing I showed you. You remember the first, just give me a minute, I will just. Yeah, just only write this classification. This is the classification which is telling you the developmental disturbance affecting the structure of tooth. Only write this. You don't have to write anything else under this.
Okay, ma'am. Thank you. Next question is it necessary to include diagrams for short essay and short notes?
If there is a diagram, it is better to draw it. For example, if taurodontism is asked as a 5-mark question, okay? You are writing all relevant points, but if you can also draw one diagram that I showed you, right, where the tooth is having a rectangular shape and the bifurcation is pushed towards the apical portion of the tooth. If you can draw one tooth like that, it is well and good, right? That will give an additional impression for you. So if it is possible, if you have a diagram and if it is possible for you to draw, it is better to draw, even for short notes and short answers.
Okay, ma'am, there is no more questions. I think there is no more doubts. There is one question has come. Is there any there is question like ghost teeth, but it is being told the question is under odontogenic cyst. Is it same as this?
No. That's called ghost cells. Okay. There is another terminology called ghost cell, because many students are not aware of this. When they hear the term ghost, automatically they will write about ghost teeth. Ghost teeth is regional odontodysplasia. That is developmental disturbance affecting the structure of tooth. Ghost cell are a type of cells that you see histopathologically in an odontogenic cyst called calcifying odontogenic cyst. There is one cyst called calcifying odontogenic cyst. The histopathology of calcifying odontogenic cyst, we will see special type of cells called ghost cells. So that is totally different. Okay, ghost teeth is totally different.
I hope there is no more questions. If there is some other questions, you can put it in your WhatsApp group and we'll be reverting back to you. And thank you so much, dear ma'am, for spending your valuable time with us. This was so much informative right from the beginning, how to prepare for the exam and to the subject-specific tips, as well as how to write a paper or how to write a question. Thank you so much. And now we have come to the end of this first session of this rapid review program. As you all know, this is spread out in 4 Sundays of this month. Hope this has been an informative session this day. And big thanks to all faculties, right from Jiju sir, Deebu sir and Jayanti ma'am. And also for the students, you have spent your time, the Sunday time to us. Thank you so much, and hope this was so much fruitful to your learning sessions and all. Take all this takeaway messages and keep learning on these things and keep improving yourself and be better be a better self of yourself. And thank you all so much, and we'll be seeing on next Sunday also. And say this to your friends and ask them to join also. And this is Dr. Jiz and Team Annoor signing off. Stay safe and goodbye. Thank you.